Welcome to today's hybrid workshop on digital twin for health system resilience at Pasca Sarjana Tahir Foundation Building, first floor, Universitas Gadjah Mada, Yogyakarta, Indonesia. My name is Dimas Sumunar, and I'll be your Master of Ceremonies during today's event. And before we begin, would like to take a moment to thank our partners for making this event come into reality. So we would like to extend a warm thank you to British Council, Middlesex University, London, London Digital Twin Research Center, TCS Research India, Techy Geeks, Kulon Progo Regency Health Office, and also Sleman Regency Health Office. And in this today, our beautiful day, as we embark post-COVID period, where we need to upskill our next generation healthcare professionals. And in this two-day workshop, our objective is to disseminate a joint program in curriculum development related to digital twin for health system resilience. And we would like to obtain input from related stakeholders in Indonesia, as well as we aspire to conduct capacity building for healthcare professionals. And during the session, I would like to remind all of the participants who attend this session physically to remind silent for the electronic devices, just to remind you. And also for you are attending in the Zoom meeting, please keep your devices muted. Otherwise, you can unmute yourself during the discussion session. And we'll proceed to the next agenda, and we are honored to have the Dean of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Professor Yodi Mahendradhata, Master of Science, Ph.D, FRSPH, and we would like to invite him to deliver his opening remarks. To Professor Yodi Mahendradhata, the stage is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Honorable speakers, distinguished guests, colleagues, ladies and gentlemen. On behalf of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, I would like to welcome all of you to our workshop on digital twin for health system resilience. As we are all aware, the rapid advance of digital technology has become an indispensable force in shaping the future of our healthcare system. So it's imperative that our health workers and professionals are not only equipped, but at the forefront of adapting to this digital transformation. The capacity and the capability of our health workforce play a vital role in ensuring that we are not just keeping pace with the digital era, but also leading the way forward toward a resilient and technologically advanced health system. So these collaborations between Gadjah Mada, Middlesex, and partners is a testament to our commitment to fostering innovation, enhancing education, and ultimately contributing to the betterment of our healthcare systems. Now, today's workshop holds a special significance as it's part of the development of a curriculum on digital twin technology for health system resilience. A concept that is not only forward-looking, but also essential for the challenges that lies ahead. Digital twin offers a virtual representation of systems, enabling us a seamless communication between the physical system and digital counterpart. So there are immense potential benefits in integrating digital twin technology into our teaching and learning environments. So in response to these challenges and opportunities, today we bring together a diverse group of stakeholders. We have policymakers, we have development teams, we have health informatics observers, and together we will try to achieve our objectives, which are pretty clear. First, we aim to share our collaborative efforts, developing a curriculum on digital twin technology for health system resilience. And then we seek inputs from our stakeholders. So your insights on the challenges and potential benefits of implementing a connected curriculum on digital twin are indispensable. And together we try to enhance the capacity of our health workers and professionals, fostering a workforce that is ready for the challenges and opportunities presented by digital health transformation. So I encourage each of you to actively participate, share your insight, expertise, and contribute to the collective wisdom that will shape the future of healthcare education and practice. Let's embark on this journey together where innovation meets education and where the resilience of our health system is fortified through the power of digital twin technology. Thank you, and I look forward to a fruitful and collaborative workshop. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Yodi, for the inspiring welcoming speech. And also, we would like to extend our warm welcome to our guest, Dr. Dzung from Vietnam National University, and also our participant from the Zoom meeting who attend this session either in the same time region or different time region. So we highly appreciate your effort, especially for those attending from the United Kingdom time. Perhaps it's still in the middle of the night, and also perhaps India time, like 4 hours early. And today, and we would like to start to discover latest trends and best practices at Digital Twin. And this session, this plenary session, will be guided by Dr. Lutfan Lazuardi, M.Kes Ph.D. And without further ado, we would like to invite Dr. Lutfan to guide this plenary session. To Dr. Lutfan, time is yours.
Yeah, thank you very much. Very good morning, everyone. So it's really great to be here. And I think we will learn a lot about the digital twins, as we already actually have 5 panelists on this sessions, that ranging from either health sector as well as also from the technical expertise that will actually share the experience as well as the examples of the real digital field, the real digital technology applied on the field. So first we will have Professor Yodi Mahendradhata, which will talk about the potential roles of the digital twins for pandemic preventions, preparedness, as well as response. Later on, we will have Dr. Souvik that will speak about imagining resilient healthcare using digital twins. And then Dr. Tuan that will speak related to the digital twin for healthcare. And also Dr. Namadev that will speak related to the learning platform for healthcare, as actually our project is also trying to improve the capacity building activity for health professionals to implement the digital twin technology as well. And later, not least, but Professor Dinh Van Dzung that will speak related to personalized care platform. And yeah, I think without further ado, we kindly request Professor Yodi to give his speaks related to the potential roles of digital twin for pandemic prevention, preparedness, and response. Yeah, so this Professor Yodi, and yeah, the time is yours, about 20 minutes. Yeah.
So good morning again. Thank you, Pak Lutfan, for the introduction. So I'm going to speak briefly about the potential roles of digital twin for pandemic prevention, preparedness, and response. Next slide. Now, a few weeks ago, I just returned from Geneva for the pandemic treaty negotiation. WHO at the moment is trying to have an agreement, a conventions on pandemic prevention, preparedness, and response. And it's a long process, but the message is very clear that basically we are living in the age of pandemics. Whether we like it or not, there will be another pandemic. And it's very difficult to prevent another pandemic. So preparedness is the key. So we need to be better prepared for the next pandemic. The devil is in the details, but in principle, those are the messages which is coming out from the current negotiations at the WHO. Now, coming back to the current, the previous pandemic of COVID-19, next slide. So let me take you back to Indonesia, March 2020. We are now in December 2023. So we've been through 3 years of a journey within this pandemic. And now if we go back to March 2020, that's the first time that the government of Indonesia announced the first cases of COVID-19. In March, the president announced the first case of COVID-19. Now, a few weeks after the president announced, we were called by several high-level officials. So I remember a few weeks later, I was asked, Dr. Yodi, can you join a Zoom meeting? We need to hear your advice. I said, okay, fine. I'll get on the Zoom. So within 2 hours, I was on a Zoom meeting. I didn't know who was going to be there. And we opened the Zoom, and there were 6 ministers on the Zoom meeting. So it was a very high-level meeting, and we were surprised because it's usually difficult to meet ministers. It takes months to get appointment to meet ministers, but at that time, there were 6 ministers there waiting, and they have a very simple, very difficult question because they only had the first 2 cases. So they were just asking me, Dr. Yodi, should we lock down the capital city of Jakarta? That's $1 million question. That's a very difficult question to answer, to tell the government whether you should lock down the capital or not at that point. It's very difficult because we have no experience whatsoever. There was very little data, very little research on how effective a lockdown is. So it's very key to actually advise the government. So we didn't have an answer, and I don't want to give them a oversimplified answer. So I just asked them, okay, can you give me a few days? I don't have the answer. So I asked for a few days, and I worked with our team. And it was very difficult because we didn't also what to do with very little data, very little evidence. So we just come up with a very rough model. Next slide. So it's a very rough model of Jakarta lockdown, which we made around April 2020. Very simple. I mean, that's the only thing you can do within 3-4 days. You don't expect much. It's just a model trying to see what happens if you don't do anything. What happens if you lock down as soon as possible? What happens if you delay the lockdown? And what are the consequences and what are the implications? So this was what we presented. And of course, they had many other questions which we cannot answer. I mean, they were asking, okay, if that's fine from a health perspective, but what is the political, social, economic implications? I don't know. I cannot answer that. You cannot get it from this model. This is just showing in terms of cases. So we were not able to address the concerns of the policymaker using this very quick and dirty model. But it was presented and it was taken to the president. But of course, then it wasn't really enough to recommend lockdown based on this. So it didn't really push for that. So as you know, after that, we different versions of social restriction and so forth, and that evolves throughout the pandemic. But that just gave an illustration of the difficulties during the pandemic of trying to make decisions during a large crisis like COVID-19 pandemic. Next slide. So I just want to share just 4 key lessons from our reflections throughout the COVID-19 pandemic. What would have helped and what would help next time if we are to face another pandemic from a decision-making perspective. And it's just 4. There's, of course, much more. But in the context of digital twin, I think 4 are potential contributions of digital twins. So we can discuss about anticipation through simulations. And then there are also in terms of real-time decision-making. And then there's also an issue on collaborative resilience. And then there's an issue of adaptive educations. So I'm going to unpack each of these one by one, just to give you an idea of what I mean by each of these. Next slide. So first, anticipation through simulations. Next slide. So what I mean here is that it would have been useful if we could simulate various scenarios, considering factors such as the rate of infection, availability of resources, effective different intervention strategy. If you have that, then it would help the decision maker if you can simulate different scenarios. So that will be very useful. Next slide. And then it will be also useful if we have the possibility to do a comprehensive risk assessment, meaning we can identify where are the weak points in our healthcare systems, which we didn't identify, for example, in terms of the health workforce, in terms of the logistic and so forth, so that we can devise strategies to mitigate this risk before they escalate, which we did. I mean, we were overwhelmed in terms of hospitals, logistic, and so forth, because we did not manage to do this. But this could have been done if we had the possibility to do risk assessment through simulation. Next slide. And then if we have the possibility to do simulation, that would allow us to optimize resource allocation by identifying the most efficient and effective strategies. Next point. And if we have the possibility to simulate scenarios, then healthcare professional can respond more rapidly and effectively when faced with real-world challenge, because you have the opportunity to already simulate and anticipate before it happens. But this also didn't happen. But this is something that we can anticipate for the next pandemic. Okay, next point, real-time decision-making. So what do we mean by real-time decision-making? Now, during any crisis, especially large crisis like the COVID pandemic, the ability to make decisions in real time is really critical. It makes the difference between really effective interventions and spread impact. So for example, when the ministers asked us whether to lock down or not, you cannot say, give me 6 months, because that's too late. They want it next Monday. So you need really quick ability to be able to make decisions. So you need to be able to do it in real time. And we didn't have the capacity. It's something which perhaps digital twin can contribute to be able to make to support real-time decision making. Next point. Because digital twin potentially offers a virtual representation of our healthcare infrastructure. So we basically have a dynamic mirror of the physical system. We have a digital mirror of the physical system. The next point. Now, if we have this, then we have the potential, we have the possibility for real-time monitoring and analysis, which could empower our healthcare professionals to make more informed decisions more promptly, not waiting for too long, and considering factors such as bed availability, resource allocation, and effectiveness of intervention. Next point. And the ability to adapt strategy in real time based on evolving crisis is crucial. We need to be more adaptable, and digital twin technology gives us the insight to make this adaptation. So that's also another important points of potential of digital twin. Okay, next slide about collaborative resilience. Now, when we say collaborative resilience, we are talking about the ability of our healthcare system to withstand and recover from shocks and stress like a pandemic through a cohesive and coordinated efforts among diverse stakeholders. Because our healthcare system consists of so many stakeholders, and when you talk about the pandemic, you have even more stakeholders. Next slide, next point. Our healthcare is a multi-faceted ecosystem. You have healthcare providers, you have policymakers, you have researchers, and you have so many other stakeholders. So collaborative resilience recognizes that you have an interdependence of these components if you want to be resilient. Next point. And digital twin potentially can serve as a catalyst for bidirectional communication and foster collaborations among health professionals, policymakers, and researchers. Next point. And it does that by providing a shared platform for information and insight. So in a way, digital twin technology can foster collaborations because you have this shared platform. So you can collaborate, you have shared insight, shared information for the healthcare professionals, policymakers, and researchers. So that's the third one. fourth one, adaptive education. This is the last one. Now, when we say adaptive education, it's basically an educational, a pedagogical approach which responds to evolving needs of learners and to ensure that our education remains effective and relevant in a rapidly changing environment. And we experienced that during the COVID-19 pandemic. Things were changing radically within a very short time. So our education needs to adapt. Next slide, next point. Now, the pandemic basically highlighted the imperative of adapting educational approaches to unforeseen circumstances, things we did not anticipate. So we need an education system which fosters resilience in both the educators, the teachers, and the students, the learners. Next point. And the healthcare landscape is dynamic. So digital twin technology can facilitate the creation of virtual representation that mirrors this dynamism. So this will allow students to engage with real-world scenarios in controlled and adaptable environment. Next point. And also, adaptive education at its core is about continuous learning. Now, digital twin technology enables students to engage with evolving healthcare situation. So in effect, it also fosters a mindset of lifelong learning. Next slide. Okay, so those are some of the key points I would like to highlight, which are reflections for our decision making during the COVID-19 pandemic. So again, about anticipation through simulation, real-time decision making, collaborative resilience, and adaptive education. And for all of this, digital twin technologies have potentials to contribute. So the way forward, next slide. What we would like to do with our collaborative project is to develop this connected curriculum on digital twin for health system resilience. This is built on this understanding that digital twin technology represents a transformative approach to strengthening the healthcare system. So if we integrate this into our educational framework, we basically ensure that our healthcare professionals are not just responders, but proactive strategies ready to face uncertainties of the future because they go through all of the simulations. Slide, next point. And a connected curriculum on digital twin technology becomes indispensable tool in preparing our healthcare professionals because it equips them with the skills to navigate through different complex scenarios and also foster a mindset of anticipation and strategic planning, not just reactive and responding. Next point. And a connected curriculum on digital twin technology ensures that our graduates are not just proficient in their individual roles, but also equip the skills to collaborate seamlessly across discipline, different stakeholders, coming back to the concept of collaborative resilience. Next point. And with digital twin, which gives this opportunity for simulation-based learning, it provides a practical and engaging method for students to actually apply theoretical knowledge by exposing them to simulated healthcare scenarios. At the same time, we cultivate their critical thinking and also their decision-making skills with all those simulations. And last point, basically, at the end, the integration of the twin technology into our joint curriculum symbolize our commitment, our investment in the adaptability and future readiness of students. Next slide. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Yodi. I think it was really very interesting presentations that gave real examples on how the importance of digital twins link with the health system as well as the effort to make our health professionals proactively get prepared of any potential challenges to our health systems. Now we come to the second speakers, which is we'll speak about imagining resilient healthcare using digital twins by Professor Souvik Barat from TCS Research India. So please welcome Professor Souvik.
So, hi, good morning, everyone. I'm Souvik Barat. I'm a distinguished principal scientist at Tata Consultancy Research. I'm also a visiting faculty at Middlesex University, London, and adjunct professor at Walchand College of Engineering from India. So can you go to the next slide? So in my next 20 minutes, what I'll try to do is I'll just give you a brief introduction of what we mean by digital twin, because if you go to any place, you will see the people are talking about digital twin, but they mean differently when we go to deeper understanding and all. So that I'll try to, and which is very similar what Yodi already discussed. So what do you mean by digital twin? And again, we did a lot of work during COVID to construct a digital twin of a city to make decisions. So basically it helps decision maker to kind of introduce certain kind of intervention, what would be the impact and all. So I'll briefly talk about that, and then I'll briefly discuss about our view of developing resilient healthcare system using digital twin. So can you go to the next slide? Before going to the point, so I am working in this field for last 10 years, and we developed a lot of technologies. So though the kind of term digital twin was not so popular during that time, but we thought probably that will make a significant change in the future. And it has a huge potential, not only for societal system or kind of healthcare system, but also business system and enterprise. And you can see some of our work along with industry. We could make a lot of impact when it comes to retail, supply chain, airlines and airport, banking and all. Basically, if you would like to understand how future will be, so you have to create a digital twin, and then through simulation, you perform a lot of what if scenario. And then kind of once you know that, okay, this would kind of work better as compared to other, then you can take those decisions. And some of the kind of, we have a lot of publication, more than 50 publications so far. And then we generally go to different top tier conferences and present our views. And so can you go to that? So coming back to kind of what we mean. So as Jody already explained, it's a virtual representation of any system. It could be a city, it could be a scene, it could be even human. You just create a virtual representation. The second thing is basically sense that system and feed into the virtual representation. So what is the purpose of that is basically you have a behavioral representation of the system, but you need to think that today you are here, you are attending a kind of talk and all. So that is your state. So that state information you need to replicate to a virtual world. And then you do a lot of analysis. It could be simulation, it could be some other kind of analysis, and you try to find out what will work better in real system. But the point is, you are not experimenting with reality. You are experimenting with a virtual system, which is close to reality, but you are not impacting that thing. So that's why we say it's a risk-free experimentation environment for decision-making or other purpose. So it's basically provide you an quantitative way of taking decision rather than taking decisions based on intuition. And this concept is not new, as I said. Even if you consider that even during Second World War, people created a representation of a city to understand where they will bomb, so that the impact will be much higher. But we are using it in different manner. We're using it very positively. And from 2010, NASA actually mandated for any kind of experimentation or any idea, they have to validate first using digital twin before implementing into reality. Why it is so? Because each experiment, so they get a lot of ideas, and each experiment is very expensive and very much time taking. And they cannot reject any of the idea by, I don't like the idea. So they have to basically come up with the scientific evidences. So that's why they created a digital twin. Their digital twin is a multi-physics, multi model, and also that's a different thing. But the thing is, they evaluate, and only potential ideas are actually experimented in a reality, because then it will save time, it will save cost, and so on. And we are trying to use the similar kind of concept in enterprise or healthcare or societal space. But the point is, these systems are not governed by law of physics, thermodynamics, or any kind of scientific laws. So there is no such equations that will tell, okay, this is my healthcare system. So you need to deal with a lot of uncertainty. You have to deal with a lot of conflicting objective. And most of the time, as Yodi was talking about, there may not be data. So even if you have very sophisticated AI, but if you don't have data, probably you will not able to do a lot of things. And most of the time, you may have data, but your environment has changed. So those data are not relevant in the current context. So these are the things. So with that, so now I think probably that's the kind of idea I wanted to communicate about digital twin, and it has a very wide impact. It can actually make a lot of difference when you are reimagining your future. And I'll talk about the kind of a case study that we have done during COVID. So, and we have a lot of publications, so some of them are listed here. During COVID, so we all know that we were challenged with, it's a trade-off between individual health safety and socioeconomic progress. So always we wanted to kind of open the things. We were not happy with the lockdown, but then things were not working as expected. So the thing is, the decision at the point of time was, when should I open a city or a kind of country? What would be the new normal? Because definitely we could able to understand after probably 2 to 3 months that, okay, there will be, we need to define a new normal. What would that be? And when is a suitable time to reach to that new normal, and so on. So, and people generally took decision based on intuition, what we thought probably, if let's apply digital twin concept and see what will happen and all. So what we created, but the thing is, as you have seen, the same virus or maybe same variant actually impacted different in different cities, or even a different part of the city. Why it is so? Because it's not about just a virus characteristic. Definitely virus characteristics make a lot of impact, but then it has other aspect as well. For example, you need to understand demographic aspect of that. What is the age group of how people are living? What is the kind of, who are the more vulnerable? Whether more people are asymptomatic because of their age factors, and all such kind of thing you need to consider. Then you also need to consider city architecture, because even during lockdown, people used to go to kind of buy some essential things. And generally, they used to get infection. And when they are at home, they used to spread through the household infections and all. So that understanding city architecture, how people are interacting with the rest of the cities are also important. And then you also need to understand what kind of interventions are used. For example, what are the administrative interventions, what are the medical interventions like testing, quarantine. So this is what probably you need to consider. It's not about just I understand this disease, or I understand the way disease progress. That will it will help you to understand how any kind of virus will spread. You need to understand the holistic picture to know how how the virus will impact to the city or in a particular geography. So that's why we constructed a digital twin by combining all such kind of aspects. So we created a digital twin by replicating virus characteristics, by replicating the demographic factor of the city. We created a city architecture and also the kind of interventions using agent-based modeling technique. I'll not go into that technical details, but this is what we created. And then we simulated to understand what would be the spread. So if things continues as is, for example, if there is no lockdown, what would be the situation? But if I say introduce a lockdown, you don't have to introduce lockdown reality. Instead, you can introduce lockdown in the virtual representations and then see what would be the infection spreads over time, or what would be the load on hospital. So these kind of things that we have done. And then you can actually experiment a lot of intervention that you are thinking. So before implementing them, you experiment those using the virtual representation, and that's what we have done. So these are the kind of, and we closely worked with, so we applied this to our city where I'm located. It has around 4 million populations. And then we tried to find out which place of the city will be impacted higher. So these are the different places in cities. What would be the death count if we understand the kind of if the situation continues as is, what would be the source of infection? So through this, we found that most of the infections are from the household. So probably wearing a mask at home could have been solved many problem, but then it was difficult and all such kind of things. Then city administrator, so we closely work with them. They gave us a requirement, or they wanted to know if I open office during first wave, what would be the situation versus if I open shop, because then you have to do a trade-off between flying essential food as well as the kind of economic progress and all. Or if you introduce weekend lockdown, what would be the situation? Or if I force people to wear mask versus and people are not wearing appropriately, what would be the situation? So those are the kind of things that we considered. Yeah, so you can see some of the representations here, which is each individual is basically represented as a dot. And then there are city things. Some of the places you can see it's congested, so they are slums. Then there are places where people are staying in a probably well-to-do societies. There are people who are commuting and all such kind of thing. And then there are two scenarios just for representation purpose. One is with lockdown, another is without lockdown. So this is how we do a lot of experimentations and try to find out which will work better and also. And then you can see some of the newspaper article at that point of time, because whatever other model were coming out, predicting point of time versus what we predicted is much closer to the reality. Can you go to the next slide? And then most importantly, what happened is after first wave in India, people thought the kind of pandemic is over. But then we did a lot of experiment and we found there is a possibility of second wave in India or in our city, which is in March 21st, which we published before. As you can see, the publication date is January 21st, 2021. We published it, and I have taken this image from directly from the publications, and reality actually happened the same time, so March, end of the March. However, the kind of we expected that second wave will be slightly milder, but then Delta was much violent, and that's why it was slightly higher than what we predicted. Can you go to the next slide? And then that's the kind of thing. And then during the third wave also, we kind of evaluated. We not only said that, okay, this will be the situation, but also we explained why we are that. So you can see the kind of Delta, Alpha, Delta, and Omicron, how they are kind of contributing and all such kind of things. And as you can see here, the blue line, which is kind of a reported case in our city, and one of the prediction that is orange line is matching closely from May, not May, but sometime after May, so June, July type. So June, July 2020 to end of third wave, which we consider the April 22. So almost it matched very closely. So with that, go to the next slide. So with that, we felt now it is time to apply this to not only in a business context, which we have had success, but also useful for kind of resilient healthcare system or probably any other societal problem. And so, but then what do you mean by, yeah, so, but when we started thinking about resilient system, so we found it's actually you need to consider the entire ecosystem. So on one side, you have patient. So you need to understand patient, there are various disease demographic factors, socioeconomic situations, and all such kind of thing. And this, we say it's a more of a demand side of the healthcare system, because it's a demand for healthcare system is increasing, because nowadays there are complicated illness, there are aging populations, there are a lot of chronic disease, such kind of things. So that is one side. On the supply, or on the kind of how the healthcare provider, there are many kind of network is there. So hospital, then we have common healthcare service, physical, then primary healthcare service, clinics, hospital, and all such kind of things. So that is the other side of the thing. So those are more of a service provider. There's a demand. And in between, there are a lot of support system like manufacturer, medicine manufacturer, instrument manufacturer, supply chain, and all such kind of thing. So in order to introduce a kind of resilient health care system, you have to consider all kind of things. You, on one side, you need to understand what would be your demand, because then you can have adequate. So, and then you need to think about how can I make those demand with a adequate healthcare infrastructure. And then definitely you need to align the support system to meet that demand by providing service. And it's basically from the system thinking perspective, it is a system of system. And there are a lot of uncertainties and dynamics. And as we all are saying, it's a fragmented data. So what we need probably is a robust and resilient healthcare system to enhance health safety for all the populations, and while achieving objective of all stakeholders. So we cannot say that, okay, we should have a better healthcare, but I don't care about the aspect of our economic goal or other kind of objective of other stakeholder like supply chain or manufacturer or even hospital. So it has to be a kind of a win-win situation for everyone to make it more resilient, and then only the stability will exist, and probably we can do much. And go to the next slide. But in order to do that, what we need, definitely we need a lot of sensing. So sensing of the environment, disease, healthcare, health-related concerns, state of the healthcare services and all. Then you need to think about two types of decision. One is, I anticipate that this will happen. So this is taken from the typical system theory, but it applies into healthcare system. Anticipate that, okay, maybe in next 5 years, this many kind of dementia people will be there, or this many cancer will be there because of the situation, how things are emerging. So that is the kind of, you anticipate situation and try to align your entire healthcare system and supply chain to meet that kind of demand, and that are more of a proactive decision making. The other kind of decision making is more of a reactive. You are in a bad state. For example, during pandemic, we were in a bad state, right? So you recover from that state to kind of the desired state. So still after COVID, we are trying to recover from the kind of that stage where we went in. So these are more of a reactive decision making. So you know the kind of state where you are. Probably you need to find the path from there to desired state, and that's what we are doing at this point of time. And in order to do that, you need to sense various things. You need to sense susceptible populations. You have to sense the demography, healthcare system, supplier, supply chain, and so on. Can you? Now, each of this, the three things that we discussed, understanding disease dynamics. So epidemiological aspect or disease aspect, medical aspect is definitely one. But as I said, other factors also you need to consider. When you create a digital twin, you need to focus on all other things like demography, people behavior, economy, city architecture, and many more things. It is actually a multi aspect, multi-perspective, multivariant kind of model that we need to create. And as you have seen for the COVID, we created 4 aspects like epidemiological aspect, demographic aspect, movements, and intervention. But similar kind of thing, if you are considering, let's say, cancer, or you are considering any kind of airborne disease. So probably you need to have a different types of model, different types of digital twin to basically understand what would be the kind of situation maybe in after 2 years, 5 years, 10 years, maybe 15 years, and so on. So this understanding is very much important. We need to work with domain expert. So definitely you have a lot of expertise in medical field, but then you need to work with others to make this kind of digital twin operational. So that's very important, and you cannot avoid that. And historical, just having historical data is not sufficient because environment is changing. Can you go to the next? The second part, yeah, can you just? Second part is understanding network. On one side, you have manufacturers, you have a lot of suppliers. On the other side, you have clinics, community health center, public health center, hospital, and so on. And in between, there is a huge network. And in this network, there is a lot of uncertainty. So, and sometimes they actually create a disturbance because of many things. And that we need to understand, because unless you understand, so definitely demand understanding, which will come from a previous model, but then entire thing you need to understand. So this is one thing that we need to consider. So how much I should replenish for a clinic, because if not ask more, if you are asking more, but if you are not utilizing, probably someone else will suffer due to that. So every time you need to take a conscious decision, and that's why the network or understanding what others require is also important, and that's what probably we need to think about. Then understanding healthcare provider. So definitely you need patient volume understanding, which will come from the earlier model, network understanding, which come from, again, the network supply chain kind of thing. And then what kind of facility that you need to provide. For example, if I take India, so 70% doctors are based out of most of the cities, whereas the requirement, almost 70% requirement are in kind of villages and so on. So in India, only 37% have access to proper hospitalization within 5 kilometers of distance. And they have only 68% patient is having outpatient OPD facilities. So this is not definitely adequate, considering that situation will change, or we'll have more needs, or probably there are a lot of growing, since the people are aging, so they need more support facilities and activities. So how can we provide, or what kind of infrastructure we need to set up, and where is very important. That again, we need to have a kind of more of ecosystem, lesson study network, and then facilities. We need to align them to make it more successful. So that's kind of thing that we need to think about. And can you go to the next slide? And how we create those, yeah, just enter. Yeah. So again, coming back to our, so yeah. So you create a digital twin of all these three things, or many more. Then you simulate, you create a simulation model, observe the KPI. If you are happy with the situation, you can be fine. But otherwise, what you can do is you can come up with a new interventions, and that intervention could come from the domain expert like you, or even there are now reinforcement learning and other learning technique available. So that will help you to come up with the intervention. You apply them, not applying them in healthcare ecosystem, but apply them in digital twin, see the efficacy and all. Once you do that, probably you will understand what you should do to define your next generation healthcare system. And the digital twin could be just one aspect, like patient, or it could be the network, or it could be the entire ecosystem. So how sophisticated or how comprehensive you would like to create it, up to you. It could be very focused or purposive, or it could be very broad and all this kind of thing. So how much effort you would like to kind of put into that kind of effort to design your next generation healthcare system. The capability exists, but what we want to do is up to us. So that's probably we need to discuss and decide when it comes to the kind of situations. So with last things, so understanding, so definitely at this point of time, come up with a resilient health system is important factor, and that's what we are focusing on. And after COVID, probably, as Yodi also was saying, there might be more number of epidemic. We need to deal with that kind of situation. It cannot be, should be in a recovery mode rather than it should be anticipatory mode. And not only COVID, but then there are many other things, disease, which are creating a lot of disturbance in the society. So that probably we need to deal with more in the anticipatory mode so that you are prepared much ahead of the situation and then you take decisions and all. So apart from that, once you have a good handle, probably thinking about food, water, traffic, energy, and all such kind of things are also have a lot of societal impact. Some of them are associated with like food and water. So most of the time, like fruits and all, if they are not reaching to you at appropriate time where food value is high, probably though you eat fruits, but food or fruits, but then it will not be useful. So those kind of thinking process also. We are doing some work with CMU, so to come up with a sustainable food supply chain. But if you are interested, or even for agriculture, so there are a lot of wastage of food every year and all. How can you deal with that kind of situation? So similar, I'm just giving some of the analogy which probably can invoke, basically trigger your thinking process, where digital twin can be used. And then water, definitely availability of water is one, but improving water quality is also we need to think about, because it has a relation with health. And then traffic due to pollution and all, you may have health issues, so you can think about those. So so one is ecosystem at healthcare system, and then if you go to our societal system, so you will see a much broader network. So it's an ecosystem of ecosystem will emerge, and that's what probably we should deal with, at least when we're talking about we'll be kind of sustainable. We'll live in a sustainable world in 2050 or 2060 or whatever the target is. So we need to deal with those kind of complexities. With that, I'll stop here, but I'll be happy to take any question, or if you are interested, go to the next slide. So if you are interested, we can have a discussion later point of time. Thank you.
Yeah. Thank you, Dr. Souvik. Yeah, very interesting. We will have a question and answer after all panelists give the presentations. But those who already have questions, then feel free to keep it the next discussion sessions then. And yeah, now we will move to the third panel. Yeah, which is will speak about the architecture. I think it's very important also to see how we should prepare the architecture, and also what challenges that will have to be faced. And yeah, we are happy to have Dr. Tuan here that will speak about the architecture as well as the challenges that we face to implement the digital technology. So please, Dr.
Thank you, Prof. Lutfan. Good morning. It is my great honor to be here to present the twin for healthcare and architecture challenges. My name is Tuan. I'm a senior lecturer at Middlesex University, London. My background is on wireless communication, so a little bit different from expertise. So I try to come with approach from different angle from the communication approach. If you could go to the next slide, please. Yeah. So this is the content of my talk. I will briefly, yes, it's well defined by Prof. Yodi and Dr. Souvik. I will re-echo some key points there. So I will talk about some features of a digital twin system. Then I talk about the healthcare system with the benefit of the system with digital twin. And then I discuss some architecture of the system, some applications, and then challenge that I see. Go to the next slide, please. Okay, so yes, thanks to Prof. Yodi and Dr. Souvik. I think it's the clearest to use that digital twin of anything. It's a mirror or replica of an object or system procedures. Okay, so it is very important that the student should have an exact model of what it is in physical domain. Also, that the student should host data of that actual system or physical system, the data in the past and the current state of the system. Could you go to the next page, please? Okay, so I'd like to highlight that digital twin is not an avatar, whereas it's the limited replica of the real system, where you don't have the ability to control the actual thing. That is not digital twin. Digital twin is not a simulation, which is having a assumption and simplification, so it's not a real model. And it is not an augmented variety of, which is only focused on the interaction of human and the actual thing. So this is not of that. If you could go to the next slide, please. Right, so as you can see here, key features of a digital twin system, it consists of the real one, or we call physical presentation, an object, procedure, anything. It has a copy of that on the right-hand side. And an important here we should have is the connection. It is kind of a communication between that virtual one and the reality one. So the more advanced in terms of connections, or you have the more updated information, data, or the state of the actual system, that's the more accuracy that digital twin you can have. Okay. So a feature of the digital twin system is that it should have modularities properties. So it has, you need to have the ability of decompose this whole system into much more smaller system, so that you have replica of whole components of system, so that you can allow the system to be involved. For example, if the technology change a certain thing, you can update that individually. Okay, so you should also have the interfaces between the components within the system, so that you can easily interchange. The highly modular is the better you have in terms of adapting to situation. So that think of when you want to design a car, for example, you have different models that you have different copy of, let's say, the engine, the brake system, so that you have almost components a copy in the virtual system. So let's say if you want to upgrade it only, so have the ability to upgrade that single component of the system. So it allows you to adapt to the change in the technology certain area, for example. And for that, it allows you to have a hybrid between the reality and the simulation. So for example, if you wish to have some features in the future, but you don't have the technologies that allow you to do at current time, you can connect that thing by simulation with that real stuff. So it allows you to do hybrid testing and development. Okay, so another feature of the digital twin is that it allows us to have remote intelligence. So think of, let's say you have a system of, we try to collect some data from patient, for example, but you have the device, wearable device you have is quite limited in terms of computational capacity. So with digital twin, you have the ability of processing the data into the cloud or the edge of the network. So for that, it allows more intelligence to the even very old version of the wearables devices. So for that, you have you provide intelligence into the limited resources system. Could you go to the next page, please? Right. If we have the digital twin, we have a life cycle of a network. So in the picture like that. So first step was the design system you want to design. Here I take an example of a telecommunication system here, where first you try to design in the virtual domain and implement this. In the design process, you have ability of testing all the what-if scenario, all the changes, so that you find optimal designs. Then you can deploy this. At the second state, in operational state, you have the ability of predict situation within the working system. And the next state is that you can expand the system. You have the ability of providing new services, for example, new features by testing using the virtual version of that. And the circle go around like this, so it allows you to involve the whole design. Could you go to the next page, please? Right, here we look at healthcare system. As clearly mentioned by Dr. Souvik, we have different parties playing that the system here. We have people, which is putting a requirement on the system, like a patient want to be taken care of. We have organization, the providers. We have people like doctor, nurses. So all are contributing to promote or restore or maintain the health of the people. Could go to the next page, please. Yep. So the benefit of having between the healthcare is that if you look at the organization aspect, we can reduce the time, wasting time or treatment time. We can reduce the workload in hospital. Imagine in the UK, we have quite high demand in terms of hospitalities. So the waiting list is quite long. Even for example, my daughter has something with her eye. It's been booked for a year, but she hasn't been looked by the doctor yet. So that kind of thing. We have to have something so that we can shorten the wasting time. So on for the other thing, we can maximize the utilization of the equipment. For example, we know a certain time, the demand on certain machine devices are high, well prepared beforehand. Yes, we can prepare the patient, for example, before they go to the hospital. So we can train them using certain equipment, for example, by using the virtuality. We provide them that abilities so that we can shorten the times for administration. If we look at the personal thing, as mentioned by Prof. Yodi, we have the ability of training doctors, nurses, or students. In terms of, we don't have to actually do on the real patient. We can do that virtually. So it's the benefit of having cell tutoring. We can evaluate a new way of treatment. For example, we can test before we do on the real person. If we look at the supplier, we can look at example of drug development here. We can shorten the time of developing a new drug. We can have personalized drug for certain people if we have the right model of that person. We can reduce the risk or net the risk side effects for drug for different people. And yes, as mentioned well by Prof. Yodi, that we can provide resilience in terms of avoiding or predicting coming pandemic situations. So that's all about benefits of having students in healthcare. If you could go next page, please. Yes. So yes, if we have students, we can provide better security. For example, in current system, we have to share the data. Even if we have a system of computer network advanced, but if you want to say between different hospitals, there are risks of breaking that privacy. And having that, looking at the communications aspect, we can reduce the amount of communication within the system because we can design the optimal way of exchanging information, exchange the data, and so on. So it is very clear that having students in healthcare, it helps a lot. If you could go to the next, please. Right, here I would like to present architecture for healthcare. So the circle, we have a physical interaction layer here, which represents the patient communities and healthcare communities, and they interact physically interact with each other via devices, equipment, for example, ambulance, gadgets, health, or for example, medical applications. Yep. And we have a virtual copy of that in the middle here, which is the digital twin. If you could go to the next page, please. Right, if we look at the patents community here, so they are the person who puts the requests on the services. For example, looking at the certain disease, they have affected by a certain disease, so they have requests be responded by doctor. So the patent committees here provides or connect to the digital by either wide or wireless connection. So for example, they have some data, testing data, or measuring data by wearable devices. So they provide that data through the digital by the connection. Important thing here is that where do we store data? Should we store it close to the patient? For example, she is at home. She had access point at the Wi-Fi router, for example. Should we store somewhere close to her, or should we put that data into the cloud? So that is a question to be think of when we design the system. If you could go to the next page, please. We have a healthcare community here. We have multiple levels like doctor, nurses, clinical specialists, pharmacists, etc. So they perform action towards patient communities. So they can do testing, they can do the treatment, things like that. They can, having the digital here, they can avoid contacting to the patient for very infectious disease. For example, they don't have to actually see the patient face to face. They can try the things using that digital. Okay, if you could go to the next page, please. Right, here we have important layer here, which is the layer. So as well mentioned by Dr. Souvik, here we have data collected by the system, and then that digital here process data using different kind of model or AIs, for example, to process that thing. The thing I want to pay attention here is that because we have that here, the question is that where do we deploy that thing again? At the edge of the network? By edge, I mean that closer to the user as a patient, for example. Or should we deploy this thing on the cloud? They are balanced. Should we think of, for example, if we distribute at the edge, we have the benefit of low latency. It means that the decision is very fast. It's because we have less delays in terms of transmitting between the user and the system. However, we face a problem of having low storage, low computational capacity, that kind of thing. At another extreme, we have if we put everything onto the cloud, we have the computational, better capacity of storage. However, you have to face between the latency, the long to the response time. So we have somehow to balance between those things when we decide in what application we should deploy at what level. Yes, if you could go to the next page, please. Here we mention some applications of digital in healthcare. We can have drug development where we have companies try to come up with new drugs they can test using digital, testing virtually, don't need to put in the real person. We have trauma management here, so we have hospital digital, so we can well prepare for the patient before they coming to the hospital. Because with that, you can predict at that time you need to go to the hospital to take certain tests, and the system will train her before coming to the hospital. So you know how to prepare for the test, for example. So kind of thing is it's helped by digital, and also as we mentioned earlier, we can maximize the utilization of equipment within the hospital, shorten the supply chain, etc. We can have applications like patient monitoring, so that we can have we monitors the patient remotely from home, for example. We can have dialogue and treatment by treatment. A third thing here we have to have, for example, if we look at the people now trying to develop the virtual human, where they try to develop the virtual brain, virtual heart, etc. Virtual kidney, for example, and then they try to capture the real thing, and they can explain on that virtual organs of the human, so that they can try different treatment method. Okay, if we could go to the next page, please. Right, there are some challenges. I'm looking here at the aspect of human. So building a virtual organ or copy of person is not an easy task that we may not know clearly about how our brain, for example, be organized. So this is very complex object. So if we can come up with close to realities, it is better. Okay, so because the accuracy of that model affects the behavior of the student and the level of response that we put to. And again, edge-based or cloud-based is important question to ask. Another is collecting information from human organs is not easy. If you want to have the real, very close copy of the brain, it's tough. You have to think of how do you send the information, how secure that thing can be. You know, when you have something that communicate with devices, you have to think of the security. And yes, cloud-based versus edge-based is most important thing when we think of when we start design the system. Okay, so with that, I'd like to thank everyone. You could go to the last page, please. Thank you. I want to thank Petit also and UGM for having me here. Thank you so much.
Yeah, thank you, Dr. Lazuardi. So yeah, I think it's really important to emphasize that there are various benefits within the healthcare for this implementing the digital twin technology. So yeah, now we will move, since that we have limited time, we'll move to the next speakers, which is Mr. Namadev from Techy Geeks that will speak about learning platform for healthcare.
Okay, so myself Namadev. So I'm from Techy Geeks. So one of the founder of Techy Geeks from India. So a little bit background of myself is I completed my bachelor's degree in electronics and communication, and I did my master's in telecommunication engineering. And then I had experience in working with different industries like retail, clothing industries, food, and finally I moved into this tech sector. So my first experience with this LMS, that is learning management system, was with a US client, which is related to this medical books, which needs to be converted into a LMS platform in an interactive way. So that is when this journey started slowly. And then, so let's move on to this meeting's agenda. So here are, in this presentation, I will be sharing a little bit of facts about the LMS and what are the, why we need to for this LMS platform, and what are the features which is involved over there, and what are the benefits for healthcare industries if you're going to offer these LMS technologies over there, and what are the key challenges which we faced while implementing this LMS for a couple of clients for us, and I've shared those as a case studies for you. Okay. So this LMS market, as per this Grand View research, it is estimated to be going beyond like 37.96 billion by 2028, and the region which is most using the LMS platform is from Asia Pacific region. And as for this adaptation which is concerned, so majority of the industries all over the globe are starting to adapt for this LMS platform, because after this COVID, the online education started to boom even in India, because before that they were not much into online educations, but later on everyone started to use Udemy, Coursera, and other online platforms to upgrade their skills. And even the corporates, they use LMS for employing their to train their employees. And then the benefits, like what they get, what exactly they are getting in return. In terms of real-time training and other things, you need more manpower and you need resources and other parts to be allocated separately for this individuals. But in terms of like online training and other things, you don't need those kind of dedicated resources or anything to be allocated. And also the people can train from their own learning path and from their own places. So this reduces the learning duration path and then increases the productivity on the corporate side and for also the production side in the manufacturing and other industries as well. So there are different industries which currently are using LMS platforms. So like service industries, and then for corporate training, they're using it. In government sectors, they're using these LMS platforms. And then in retail for training their employees and like to providing customer services and how they can take it forward to the next level. And in education sector, it plays a major role over there. And then for manufacturing industries also, it is playing a vital role in training, providing virtual training for their employees. And then the importance, like why exactly we need to go for it, is that it provides consistent training. That is, no matter where you are located in part of the world, you can still carry on your work, or you can still continue your learning path in your mobile devices or in a laptop devices, the course which are dedicated to learn. And it is also like time efficiency. So you can learn from your own pace. There is no compulsion that this should be completed in this many hours or anything like that. So this is also one of the major plus point for this online LMS platforms. And the people who are opting for the online LMS platform is they are eager to upgrade their skills to move to the next level. So obviously their dedication and everything is more into about learning new technologies and upgrading their skills for the next level of state. And the key features in general LMS platforms. So there are like 3 different users. So one is the basic user. As myself, I'm going to learn a particular course. So from my perspective, I'll be able to choose the course which is apt for me, not from my capability. Like I have this much limitations of time which I can allocate per day, and I'm willing to learn this design course or any other programming course from RN. And so I can choose based upon my own interest. And as for the tutor side, he has his own command over the content which he's going to share. And the content which he's going to share is already been created from his own end, and he can manage the number of users, and he can collaborate with the users and clarify those contents or any other queries with the general users which is having. And he can also provide the content in a gamification way, where you can even provide in a video aspects or quiz, or in a AR or in a VR aspects also. You can provide the same content, and he can have a track of the learning paths and everything, and he can manage the number of users. As for the reporting and other things are concerned, so the super admin and the admin part, they will be taking care of the reporting sections, the revenue parts, the feasibility sections, the technicalities over there, and the customizations and the improvisations of each and everything over there. And how this is going to benefit in terms of healthcare. So in terms of healthcare, the content, the sender, what do you call it? The data or the information which you are going to learn will be in centralized. For example, if you are going to take a university or medical college, so all the lecturers or informations will be in a centralized part, and any student from anywhere of the particular enrolled universities can start learning on this particular path, and he can choose his dedicated section on this part. And it allows them to collaborate with different users. That is, even from different parts of the world, he can have a conversation with the other user who's enrolled in the course. And this information, like staying up to date with the current technology trends and each and everything, helps the user to move it to the next level part. And the major plus and minus is the data security and compliances, because as far as the other streams are concerned, so data security and compliances are a little bit less. But when it comes to healthcare sector, so the major thing is the data security and compliances and the privacy part. So these 3 things needs to be taken care of. And very vital role. And also the adapting to the recent technologies, because the normal programming skills, you just need a programming platform over there. But in terms of exploring a healthcare related informations, you need to provide the content in a interactive way where they can play around with the content and they can see how things are visually or in a gamification way and other aspects. And the challenges which we faced with a couple of our customers and in our products is, the first thing is the user experience, because the majority of the people who are using are from non-technical background. So they want the features or the functionalities which is over there to be very simplified, not much into more detailed or what do you call, more complicated features or anything, just straightforward and more simple design and more simple one. And the next one is the compliances and certifications. So the certification which is going to be provided after completion of the course or anything, which is need to be decided by the authority of the university, particular university or the hospital who's handling these LMS platforms. So they take care of this regulatory parts and the compliance and certificates and everything. And the next thing which comes into is major thing is the cost of implementation. So as an individual user, if they are going to launch it, then the budget which they have is very, very less. And as for the university or for a college or for a small clinic which they're going to have, the budget varies depending upon the individual user. For corporate or for automobile or manufacturing industries, they have a limited budget and they can allocate more in terms of if they're going to increase it, they can allocate in the future. But for a small organizations, this is a major drawback when they are trying to implement this LMS for their own clinic or for their own tutorials. And obviously the security aspects. So the content which they're going to put, and they need to make sure the user's data is more secure and the privacy policies maintained properly. And also the normal user should not have access to this particular contents outside of the particular applications. So apart from this assignments or other tasks, they shouldn't have any access apart from this, because it is more sensitive and it is more complicated information which cannot be shared to other general public as it comes to this healthcare industries. And also the adaptability to technology advances. This plays a key role in this. You can imagine like you're interacting with the brain in a AR environment where you can split the brain and you can see the cerebrum and other parts of the brain virtually. So for this one, you can also integrate in provide the learning experience in AR aspects in VR, and in terms of XR also there are like other options which is currently being deployed with one of the big companies like KLAs and other they use for their services in XR and the technical feasibilities. So based upon the requirement and based upon the requirement, the budget, and the content, everything. So we arrive at the technical stacks and then we deliver the content to them in a user-friendly manner. So the couple of case studies which we came across is the first one is with the hospital part. So they already had an LMS platform which is with them, but they are unable to use it because of this difficulties which they face, because they are new to this LMS platform and the previous admin or whoever worked there, they are not aware of what exactly is happening at the backend part. So that is the major difficulty which was faced from their end, and also the feasibilities, because the technology is advancing and every year or every 6 months on they are releasing a new version, and the current version of the LMS is not being supported for the next level features to be integrated. So they face that particular thing. And also when the number of users in the particular hospital increases, they are facing the performance degradation as well. And so they requested us to create a new system within a low budget, and the major focus is that it should be user friendly and should be compatible for all devices. That is their major focuses. And the way we created is that we started from the scratch, that is from design, and then we explain to them like this is what it will be and how it will look like and how the user experience will look like and everything. So once we created for like the mobile app and for web app, and then later we deployed it to the cloud, because as the number of users is going to be increased, the dedicated server or the shared server which is going to be either in the in-house or which is purchased from the domain will not be suitable for the long run. So if it is going to be hosted on the cloud server, then for them it is a feasibility that they can increase the number of users without reducing the performance of the particular system. And also the new users or the other parts who are opting in or who's going to join this particular admin sector or for this tutoring sector to upload the courses and everything. So they need to be aware of what exactly and how they're going to use it. So we provided the a manual for them and the video tutorial and the direct sessions, like every 6 months once we provide them the sessions for this, for the deployed LMS. And for this online tutoring platform, the same. So this is completely different one, but almost this healthcare LMS and this online tutoring platform is almost same. Here, this is only for the students, for the school students. So here they have an option to enroll for different courses which they are going to opt. Also, there is a login for the parents, so they can check like what is the they can check what in what courses the students are in, children are enrolled, and what is the current status of the course which they are doing, and they can have a monitoring aspect. And as far the teacher is concerned, and as far the teacher login is concerned, they can provide assignments on a regular basis, and they can keep track of what is the status of the assignments which is provided and everything. So they want this to be deployed for different devices. As for it is deployed for across India. So they want it for the web version and for the Android and iOS version. And to make sure that it is not degrading, so we also deployed it in AWS Cloud for them. So these are the couple of challenges which we faced and which is currently over there and going on in the health industries in LMS platform. So I think I finished in less time.
Yeah, thank you very much.
Yeah.
Yeah, I think it's very important.
Very quick.
Yeah, thank you very much, Mr. Namadev. I think it's really important session also to consider the capacity building, which is actually part of our projects that expected then to have a course module delivered using the LMS. Yeah, I think it's important activity as well as to ensure that what we do is then will be also useful for other health professionals. Okay, now we reach to the last panelist, but not least. We invite Professor Van Dzung, the Deputy Director of Information Technology from Vietnam National University in Hanoi. So,
good morning. My name is Dzung from Vietnam National University. Right now, I'm in UK for Horizon Project, so it's early time in UK. I'm happy to present the things that we're doing right now. We call personalized healthcare platforms that is related to digital twin as well. So there are two issues that I want to present. First is a build core platform that we use for personalized healthcare, and also could be used for digital twin development. As the next part is how personal healthcare platform implementation is going on, and what we are doing and what we're expecting to do in the next future. So here's architecture that we call build core digital platform that could be used for any smart applications, including the healthcare. So you hear. So it looked like complicated architecture, but it consists of 4 parts. First one is IoT part. So that is a part of sensoring that collecting data from patient or the environment. And the next part is the communication networks that like internet. And the third part is very important. We call the core platforms that include the IoT for collecting the data and big data platform that for batch processing and real-time processing data. And the third very important thing is the AI platform, that's the core platform that could be used for a different industry, including the healthcare platform. So basically, distant twin system could be developed in this area based on the core platform. So in the other view that we can see that how we can establish the digital healthcare ecosystem. So if you look at the left side, the important thing that we can collect, how we can collect the data. So on the left side, that's the solution we call data ingestion that collects the BAT data, and for real time we call the IoT. So basically is a solution available for data integration. And the next part is how to store data. So we call the data lake platform. And the next part is the data processing that includes real-time, math, and machine learning or data ops. So that is the AI laboratory in the cloud that data scientists can working on and for deploying the digital health or the application of digital transformation to medicine, modern in that. And the next layer is how to integrate the train model into the application that could be used for healthcare ecosystem, include the medical doctor, the patient, inpatient, outpatient as well, and distant field object. So the basic idea for personal healthcare is to provide to manage the chronic condition for the people who want to take the health and wellness, and for the people who living independent longer for elderly people. So the basic that the business model that we are moving is to move this figure from stage of wellness, pre-illness and illness to this figure. So basically, when the people are getting out, so they keep their health, in the first stage of the wellness. So that's the objective of the system. And the system, the coverage or scope in here on the red color. So basically, usually the IT application go with the hospital, the clinical, that's the clinical application in hospital, and the in-person or offline in hospital between the patient and the medical doctors. But our system working on the online manner, like the online hospital, and go with the people, work with for the people who stay at home or outpatient. So that's the scope of the system. So basically, for the system that we implemented now is for we call it precision cardiovascular medicine, and right now we are collecting the data, real-time data from wearables of the people who can wear it at home or in outside of the home. And also the data come from the hospital, we call it clinical data. But in the future that we have to take a multimodal models. So the data could come from outside, like environmental data, and also from experimental data, and biological data, like between the correlation between the gene and the disease. So it could be talk about the DWAS metric could come for this side. So then when we have a different kind of multimodal data, we can go to the AI normal training and serving, like a feature engineering and taking algorithm selection, and go for development, modern development, and taking an evaluation process. And there, so that is the thing that how AI could play in that the platform. And here's a very basic conceptual design of the system. If you can see from that, the data the people are stay here, and it getting data from the watches and different sensor at home, and then go into the IT platform that I mentioned in the previous architecture, and then it can go to the back end of the platform. So here's we call a personal healthcare platform. So this system receives the data from real-time data from the people as a patient, but also from different data set kind like clinical data, medication, genome data, environmental data as well. And it go to the different stages, as I mentioned earlier, in architecture, like a data ingestion, a data lake, and go into this one. And basically, train model is integrated into the AI microservice application in here, right? And then the AI, the real-time, they come good to this one. So combining that's the input for the train model. So the output is for the patient, for the medical doctor can use the app and the web interface to see their condition for diagnosis and for treatment. So basically, you can see that in this distant twin view, the medical doctor can work with the physical patient here, and also the object, the virtual patient here. So for treatment that can medical doctor have with the help from AI, he can make some kind of simulation with emulated patient here on the right side before making decision for real patient. So that important thing that distant twin can important like trying without error in the physical patient before making a final decision to a particular patient. So right now we have developed, you can see the interface, the kind of application interface is kind of snapshot that can be used for patient, for medical doctors, for different functionality of that. And so basically we can see that, so that's the ecosystem between the AI can support medical doctor, the AI can support the patient, and the medical doctor can work with the physical patient remotely, or can work with object like a simulated patient. So that is the different, that the new hand care process with considering the digital transformation to the medicine. So what's the current status and vision of our team? You can see the last year we have a prototype working with smartwatch, and we working the data set with the heart disease from UCI in data set, and we work with different machine learning algorithm like a Pearson correlation coefficient and information gain, DBS scan, and XGBoost library. And this year we improved the algorithm and working in how to put the train model into the cloud. That important thing that so basically we have that we call 0.7 release, and from next year we hope that we can develop, we can collect more data apart from UCI dataset, like from Vietnamese dataset. So basically we work with National Hospitality of Heart Disease in Vietnam, and hopefully that we can work on that manner. From point of view of AI, we work on different approaches for running the AI model, like multimodal data, real-time machine learning models, and meta-learning models. So, and then smartwatches integration, that we can work not only in one smartwatch, but also the other different smartwatch brands, like from Samsung, from Apple as well. So big vision deployment for international user and Indonesia. So I hope that we have a chance to work with you and in the future, because I have been to in Bandung 25 years ago, and I hope that it comes again to Indonesia to work with you and in the future joint project. So the vision is not only working with smartwatch, but also work with different data sources mentioned before, like the pharmacy medicine, the medical records that the patient taking during their treatments, and also correlation between the environment and disease. That's the topics that raised now that I'm working with different UK the team in here, that we hope that we can make a kind of a future correlation between the air pollution related to cardiovascular disease. Also from research, education, data set and research could contribute to that manner. Like, you know, in UK, they have biobank, very big system. So whether we can make correlation between the genome and disease. So that is a very potential future for a personal healthcare system in general, and in our for particular for our system as well. So that is all of short a brief of what we have done, what we're doing, and what we're looking for the future for collaboration. Thank you very much.
Yeah, thank you very much, Dr. Dzung. I think very interesting also to see what you have done, and this is we in line also with what we are trying to do here. That we try to also integrate the data from electronic medical record as well as with the several disease registry like cancer registry and also the biobanks. And yeah, now we have several minutes for questions and answer. We kindly ask, yeah, especially uh, Professor Souvik and also Tuan Lee, which is come in person here to stay on in front of the audience. And we have, I think, several minutes for discussions, probably 15 minutes more. So please, those who would like to ask, yeah, Anifa. Those who would like to post the questions in the chat room, especially for who is joining online, feel free also to do it.
Yeah, thank you, Dr. Lutfan. Thank you so much, all the speaker. This very interesting information, and as we know, digital twin is quite new in Indonesia. Yeah. So, what I want, I'm Hanifa from Department of Health Policy and Management. What I want to ask is, what to prepare? First step to prepare if we want to model the digital twin with the health data in Indonesia, because one of the challenges about data in Indonesia is still fragmented with a lot of application, and who is the multidiscipline expert that maybe need to collaborate? Yeah, thank you.
To whom?
Yeah, to Tuan Lee and Souvik maybe.
Yeah, all panelists can give answer as well. Yeah, please.
Yeah. Hi. Yes. So that's very important question because we need to understand how to prepare ourselves to create a kind of digital twin. Few things we need to consider. So digital twin is always purposive. So we need to define the purpose of the digital twin. For example, the example that I have shown is only to understand how COVID will spread in a particular city. So, but then when you are talking about in general healthcare, so it's very broad, but we need to narrow it down. Then there are two things that there are several ways you can construct digital twin, but there are two things you need to focus on. One is the collecting. So first of all, you need to understand who are the stakeholders in this, who will be impacted when you are actually thinking about the particular purpose. And collecting the domain information. Data is definitely important, but collecting the domain information from them is the first thing that we should focus on. And once you have that, then there are many ways you can capture that domain knowledge based on what kind of clarity you have about the domain knowledge. You may have very precise understanding of certain aspect. You may have a very broad level understanding on some other aspects. So based on those understanding, we first generally created a digital twin or virtual replica. The second thing is, as I have shown, the first is basically replicating the behavioral effect and from the various perspective. Then you need to collect data and feed that data into the model so it will be served as a parameters to that model. So typically, if it is pure AI-based model, then you need to start first focusing on data. Otherwise, if it is typical digital twin, you need to focus on the domain understanding. And that is a kind of, since you all are a domain expert in some field, so first you should focus on that instead of what data that you have. And then you collect data, feed that data into the model. Then you can do a specific type of analysis. It could be simulation. It could be some other types of analysis like predictions using AI model and all. Most of the time, it is not only AI model. AI model play a very important role, but it is a multi-model kind of digital twin is very much required to solve the problem that we are dealing with. That's my view at this point of time. Tunde, if you want to.
I just want to add a few small thing to that. What Souvik has clearly mentioned that you have narrowed out the purpose for what we would like to implement. For example, for supply chain, or on persons, or in for example for hospitality, for example. So we have to focus on that. And then that is my comment.
Yeah.
It's very important when we say that we created digital twin.
Yeah, thank you.
Yeah. Any other questions from the online participants? Any? Yeah, I actually have follow-up questions regarding what Hanif already mentioned, since that we actually also plan to do. And in terms of the data quality, usually in sectors or especially that data from the surveillance is probably problematic in terms of the quality. So we are actually still have to do a lot of effort to make the data is in high quality and ready to be used. But in that case, if we probably have no good data, but I think one of the strategy to improve the data quality is also to use it. And we realize that the data is not yet good at this moment. And how do you suggest that? What will be then useful in this case? Yeah.
Yeah. So this is another important question we need to deal with. So we always so we need to change our viewpoint a bit, because I said just data will not lead you anywhere, even if you use very sophisticated AI technique. Why it is so? Because it is observed not only in healthcare system but also business system. For example, I want to create a kind of I conceptualize a new product, let's say telecom, because all of you use some of the telecom product. And I have, so if you go to any telecom company, so they have data about their customer for last 10 years. And it's very precise data. They have what kind of use that you have, where you paid, where you have moved, and all kind of data that have. Now, based on that data, if I try to create a kind of new product, the problem will be, so though the data exists, and as per their kind of situation, the data is valid, represented, because they generally capture all the interactions. But the thing is, your preference is changing. Consider the way you used your telecom service before 3 years or 4 years, and the way you are using telecom service is quite different. So data is not talking about the future, data is talking about the past. And more importantly, you need to think about data says what happened. Why it happened, it never says. Probably you have to interpret that. And that's why when you have to create a digital twin, data, we all are saying data is important, but data is not everything. What you have, at least in the healthcare system, you have very rich domain understanding. So let's focus on capturing that. And then even if you have fragmented data, they are valid for, let's say, for very limited context. The remaining things needs to be all the remaining information which you see it's missing in the data should be plugged in through domain understanding. If you do that, suddenly you will see these kind of problem will actually goes away. That's what we do as at the when we create a digital twin of any enterprise. Even there during COVID, all the data exist during alpha variant was not valid for delta. What that mean? So if I just rely on historical data, we'll end up with something which happened in the alpha variant, which is not the case for delta. Similarly, what happened in delta doesn't make any sense for Omicron. As you have seen the curve, when Omicron is taking over from delta, it doesn't make any sense. It makes sense to certain extent. So go ahead with the kind of data as a big data. Consider it, let's accept the fact it is fragmented data. Consider it's a data. You create a kind of surrounding by augmenting the data with domain understanding. You will get a much richer information and knowledge for doing decision making for the future. That's the kind of hypothesis that we consider when we apply digital twin for the business as well as societal context. So you want to add any point?
Okay. Yeah, thank you. So I think there is a question. There is a questions from the online participant.
There's question, Pak Lutfan, from Dr. Ahmad Hidayat.
Oh yeah, yeah. Please, Dr. Ahmad Hidayat.
Yeah, thank you, Dr. Lutfan, for the opportunity. My question is to Dr. Dzung from Vietnam. I want to learn more from you in terms of what is the interoperability standard that has been applied to the framework that you have presented? And also, is there any experience that we know the data from the IoT and medical IoT are very critical and invaluable. However, how's the experience of clinician using this data for treating the patient? Thank you.
Oh. Okay. Thank you. There are two questions, right? The standards. So there are different kind of standard we apply for. So in the application in data manners, we apply HL7 release 5. So that standard that very detailed description of data scheme over there that we apply for our system. In terms of communication, so different. So basically, how we can connect different IoT devices from different vendors. So we need some kind of protocol like MQTT or CoAP. So that's basic is the international protocol. That protocol follows international standards from ISO. So we believe that can have good integration for different devices, especially for medical devices. For the second question is the data reliability from IoT. So if you see that, the collecting data from smartwatch or any medical devices is not, the accuracy is a very big problem. So we have some kind of, so it's compared to the medical devices in hospital. So so we consider the system applied for pre-screening, so kind of making some kind of recommendation warning, so we can take a kind of acceptable accuracy rather than is kind of official treatment or diagnosis procedure like in hospital. So let people know that what's going on with his heart disease, and he has to work with remotely with medical doctor. So if the medical doctor decide that okay, you have to stay at home or you go to hospital to have a traditional medical procedure over there, so that is the procedure. And so that is, the answer to the questions. Yeah.
Yes, thank you very much.
Mm.
Yeah, next, I think Dr. Ferry would like to ask also, please.
You for the chance to ask. First of all, I would like to say thank you for the very interesting presentation. I have some questions to be asked. The first one is currently Indonesia is implementing Satu Sehat, where is the process of integrating the health system refer to already established standards such as fire, stormwater, lowing, and etc. What I would like to ask you is where is the position of the digital twin in this manner? Can we adopt the digital twin and Satu Sehat simultaneously? Is there anything that we need to adjust so we can use the digital twin while we also try to implement Satu Sehat? My second question is for Mr. Namadev. Thank you for your presentation. It's very interesting. I believe that increasing human resource competency and literacy is very important, and the LMS model is very useful and suitable to be applied at this time. My question to you is, what are the steps in building a good LMS, and how can we collaborate so that we in Jakarta can build and or utilize existing standard LMS products? Thank you.
Yeah, thank you, Dr. Ferry. So the question is related to the government initiative to integrate the health data into Satu Sehat platform. So it's actually platform expected to integrate data, health data from various sources and different type of health data as well. And the question is, where is the locations of digital twin in terms of this? Any probably or probably also potential significant if we already integrate the data. Yeah, I think this will be to Souvik and look.
Yeah. So as I said, data play a very important role, but it is not. It's necessary but not sufficient. But the thing is, if we have data, then definitely we can do a lot of things. So that integration is very important. So that data will tell you the current state. So for example, if there is any system, so the system is, and you are collecting data from the system, you are integrating that data into a kind of somewhere, it will give you a very good perspective or visualization of where the system is. And if you are happy with that system, then you can continue as is. But if you are not happy, what is the future of that system? That's the question. Typically, we need to ask. If you are happy, it's okay. You keep on adding data. You prepare for the future, it's okay. But if you're not happy with the kind of the way it is working, or you may see that there is certain changes, you need to introduce certain change in the overall system. It could be in one of the IT system, it could be in the overall process, it could be any of the healthcare system that we see. Now, who will do that? One is definitely, if you have data, you provide a good visualization and domain expert can say, okay, you should do it. But then if you will do it more scientific way, you can use digital twin. So combining the capability that you are creating along with digital twin, it will not only give you the insight of the system, it will give you the far side of the system. That means if I want to do this, this would be the impact, and that will produce something, some more data for the future system, not only the current system. That's the kind of role that we play by combining what you are doing by integrating various system data along with digital twin. It will be much powerful to reimagine future system in some sense. That's what my view is. Yeah.
Okay, so then the second question, please, Mr. Namadev, related to
Yes.
the.
Hi, very good morning. And can you repeat your question, please, one more time?
Yeah. My questions are first, how to build a good LMS. What are the steps to build a good LMS? And the second one, how can we collaborate so that Jakarta can develop or use the existing LMS product that you maybe already have? Thank you.
Okay, so your question was related to the collaboration, LMS collaboration, and then related to the use of existing LMS platform, right?
Yes.
Yes. Okay. So in terms of collaboration part, we are open for collaborations for this. From our existing LMS platform, we can deploy it to yours, or we can deploy it in your own cloud, and we can give access to your team members. And in terms of other data and other aspects, the compliances and everything changes from country to country, and also from university to university also it changes. So those compliances, regulations, privacies, and everything, it needs to be taken from your end. And as far as the technical aspect for deploying part and the maintenance part and the training sessions and each and everything, will can be taken from our end itself.
Okay.
Does this answer your question?
Dr. Ferry, any further comment or it's enough? Okay, I think because of the time constraint also, we have to close the sessions. But yeah, thank you very much for all panelists. So give applause to all of them. I think it's really very inspiring and also a lot of lesson learned from these sessions. Yeah, thank you.
Thank you.
Well, thank you very much. And let's give one more round of applause for the exciting panelists and moderator for the first plenary session. And as we have limited time and would like to proceed with the next agenda, which is the panel discussion from Indonesian stakeholders. And while we're taking short break, so anyone of you who would like to go to the toilet, so you just need to go outside and directly to the west or the right hand side. And who would like to invite to our upcoming workshop with Indonesian stakeholders, where we will have the opportunity to learn and get insight about the local perspective. And ladies and gentlemen, please join me in welcoming our honorable moderator, Dr. Guardian Yoki Sanjaya, MD, Master of Health Informatics. To Dr. Guardian, the stage is yours.
Yeah, thank you, Mas Dimas. I guess you get to mention that we can use Bahasa Indonesia as well, right?
Yes,
Yes,
that's correct.
okay,
And we have
because,
interpreter services.
yeah, okay. So how our guests can use these interpreters? Is there any
Well, unfortunately for our guests, they need to join the Zoom meeting and then they activate the volume or the speakers, then they can access that interpretation services.
Yeah, I think so, because we have two guests from abroad and they are here now, and we have to facilitate them with interpreters. Yeah.
Yes, we'll find a way for them.
Okay, great. Please help them to, because some of us probably will present in Bahasa Indonesia. However, I would like to introduce in English first. And of course, the speakers can present in Bahasa Indonesia as well. And thank you, everyone. And I think these sessions would be the experience of Indonesia related to the implement the digital health. And we have four distinguished speakers and two online and two offline. And I would like to say hello to Dr. Ahmad Hidayat. How are you? Okay, he's raised his hand. Are you? How are you, Dr. Ahmad? Good.
I'm fine, thank you,
Okay,
Dr. Guardian.
okay, thank you for attending this seminar. Dr. Ahmad Hidayat is
My pleasure.
of the Technical Working Group Indonesia, Satu Sehat, as Dr. Ferry mentioned the Satu Sehat is a platform of the interoperability that provided by the Ministry of Health. Actually, not only the interoperability, but like some kind like a branding of digital health implementation in Indonesia that initiated by the Ministry of Health. Since 2020 and 2021, there was a roadmap of digital health, and then until now, we're moving to using the electronic medical record to be interoperable between one to another that facilitated by the Ministry of Health. And we have also a second speaker from the representative of the Provincial Health Office. We have here Dr. Ferry. Hello, Dr. Ferry. Okay, I think Dr. Ferry is already there too, and he is the head of the unit of the data information and public relations of the Provincial Health Office. And yeah, it's a little bit different from other province because they have a specific unit for related to the data and information. And I believe that we can learn lots of things about this unit and also the activities in the Provincial Health Office. And the third speaker, we have Purwadi Sujalmo. Oh, okay. Oh, Mas Purwadi. And he is from the UGM Hospital University or Academic University. And he has experience working with development of the digital health in the hospitals, especially for last time we discussed about early warning systems. For nurse, he is a nurse, and he actively involved in development of the digital health in the hospitals. And the last speaker will be Professor Dr. Ghufron Ali Mukti. However, we have to wait because he is in the middle of the other agenda there. But he will come soon in our faculty. And for the first speaker, I would like to provide to Dr. Ahmad Hidayat. He will talk about the importance of the consultants of the implementation of the Satu Sehat. Satu Sehat is a platform, is a branding, and not only a platform, but branding related to the digital innovation in Indonesia that initiated by Ministry of Health. Dr. Ahmad, are you ready?
Yes, sure. Thank you very much.
Okay. Okay, time is yours, Dr.
Yeah,
Ahmad.
please. Thank you, Dr. Guardian. Let me share my screen. Thank you very much for the committee for inviting me for this session. As mentioned by Dr. Guardian, I'm sorry, I didn't anticipate that the session will be solely in English, but I prepared the slide in Indonesia. But I'm happy to explain it to English. But I will present it in Indonesia. I hope the committee in the venue can help the foreign guests to understand my presentation. But from time to time, I try to explain it in English. Today, I'll be covering the topic about the role of consultant in Satu Sehat implementation. But first of all, I would like to introduce what is the technical working group. I'm sorry, I will start to explain it in Bahasa, but please feel free to ask question if you have any. Ini bagian tentang technical working group yang Bapak Ibu mungkin sudah banyak ketahui, terdiri dari para profesional, akademisi, juga asosiasi serta industri yang berperan untuk memberikan masukan kepada Kementerian Kesehatan untuk memfasilitasi percepatan implementasi Satu Sehat. Ruang lingkupnya termasuk memberikan rekomendasi dan juga melakukan monitoring evaluasi terhadap implementasi Satu Sehat. Bapak Ibu sekalian, pada kesempatan kali ini saya ingin memberikan ruang lingkup terhadap topik bahasan kita pada siang hari ini, yaitu mencakup tentang konsultan manajemen yang dimaksud di dalam sebagai konsultan dalam topik ini. Ini topik yang sudah cukup lama kami bicarakan dengan Dr. Guardian, Dr. Lutfan terkait bagaimana peran konsultan untuk melakukan implementasi satu sehat ya. Kenapa konsultan manajemen menjadi relevan untuk pembahasan pada topik ini? Karena implementasi satu sehat itu juga mencakup tema dari workshop ini sebagai satu digital twin untuk ketahanan sistem kesehatan. Ya. Kemudian juga sesuai dengan audiens dan juga membahas konsultan manajemen kesehatan tentang yang sudah dibahas di workshop ini. Ya. Dan kemudian juga peran konsultan manajemen kesehatan dalam memberikan pandangan, arahan, dan evaluasi yang bersifat manajerial, tapi juga bisa secara strategik sebagai peran dari konsultan manajemen kesehatan. Dan poin terakhir yang disampaikan pada poin bagian ini adalah konsultan manajemen kesehatan mempunyai kerangka regulasi, yaitu berdasarkan PMK nomor 18 tahun 2019. Nah, apa saja yang dimaksud dengan konsultan manajemen kesehatan sesuai dengan PMK 18 tahun 2019, bahwa konsultan manajemen kesehatan adalah tenaga yang mempunyai kompetensi profesional dalam menyediakan jasa konsultan kesehatan tertentu di bidang manajemen kesehatan. Konsultan manajemen kesehatan terdiri dari manajemen fasilitas kesehatan, manajemen kesehatan masyarakat, manajemen administrasi kesehatan, dan manajemen penunjang kesehatan. Di mana teknologi informasi masuk kepada manajemen penunjang kesehatan. Bapak Ibu sekalian, tadi sudah disinggung sedikit tentang satu sehat. Saya hanya ingin membuat satu rumusan yang saya coba sesederhana mungkin, yaitu satu sehat adalah platform digital terintegrasi untuk menghimpun data kesehatan dari berbagai sistem informasi dan aplikasi kesehatan, baik melalui portal terpusat maupun aplikasi mobile untuk pengguna individu. Jadi satu sehat tadi sudah disampaikan juga oleh Mbak Hanifah bahwa saat ini aplikasinya masih banyak sekali yang digunakan, namun demikian sedang diupayakan agar aplikasinya bisa diintegrasikan ke dalam data-datanya ke dalam satu sehat. Nah, tujuan daripada satu sehat adalah untuk mengintegrasikan data. Dan tujuan daripada integrasi data ini adalah untuk meningkatkan pelayanan yang lebih baik. Siapa saja yang memanfaatkan satu sehat, ya, yang bisa memanfaatkan satu sehat, tentu adalah para individu dengan data-data yang dikumpulkan dari berbagai fasilitas pelayanan kesehatan. Satu sehat mobile memberikan informasi tentang apa saja jenis layanan yang sudah pernah didapat oleh seseorang di aplikasi satu sehat mobile-nya. Kemudian komunitas ini juga akan memberikan atau mendapatkan manfaat yang dari integrasi data dari satu sehat. Kemudian para peneliti serta industri kesehatan. Dan tidak terlepas dari peran daripada fasilitas pelayanan kesehatan. Di satu sisi fasilitas pelayanan kesehatan merupakan penyuplai data dari satu sehat, tapi di sisi lain fasilitas pelayanan kesehatan seharusnya mendapatkan porsi untuk bagaimana data-data yang sudah dikumpulkan dapat mendapatkan umpan balik untuk dimanfaatkan. Pemerintah daerah juga tentu di sini memegang peranan penting. Nanti kita akan banyak belajar dari Dr. Ferry tentang bagaimana peran pemerintah daerah dalam integrasi di satu sehat. Dan tentunya Kementerian Kesehatan merupakan stakeholder atau shareholder yang paling penting dalam memanfaatkan data-data di satu sehat. Dan tentunya BPJS Kesehatan, walaupun BPJS sudah mempunyai data-data yang dikumpulkan dari fasilitas pelayanan kesehatan, namun dengan penambahan variabel-variabel data yang dipunyai oleh Satu Sehat, tentu data-data di BPJS Kesehatan akan menjadi komplement dengan data-data Satu Sehat dan begitu juga sebaliknya. Nah, Bapak Ibu sekalian, ini sedikit menggambarkan perjalanan transformasi digital di Indonesia, diawali di pertengahan tahun 2021, di mana ditetapkannya transformasi sistem kesehatan, di mana salah satu pilarnya adalah transformasi teknologi kesehatan. Di antara 6 pilar transformasi kesehatan. Dan pada bulan Desember tahun 2021, pertama kali diluncurkannya peta jalan transformasi digital kesehatan, dan kemudian adanya platform Satu Sehat, dan hingga saat ini kita sudah mendekati pada akhir tahun 2023, di mana ini adalah batas waktu dari penerapan rekam medik elektronik bagi setiap fasilitas pelayanan kesehatan. Nah, dari sisi regulasi, sudah cukup banyak regulasi yang sudah dikeluarkan oleh Kementerian Kesehatan, mulai dari kaitannya dengan Fasiankes, maka Permenkes 24 tahun 2022, yang mana isinya antara lain adalah menetapkan penggunaan rekam medik elektronik, dan di sisi lain adalah penetapan tanggal 31 Desember 2023 sebagai batas akhir penerapan rekam medik elektronik. Banyak juga keputusan Menteri Kesehatan yang sudah dikeluarkan untuk memberikan rumusan dan acuan tentang bagaimana implementasi sistem elektronik di fasilitas pelayanan kesehatan maupun di Kementerian Kesehatan. Dan terakhir juga telah dikeluarkan sanksi administratif bagi fasilitas pelayanan kesehatan yang belum menerapkan rekam medik elektronik. Tentu saja ini akan bertahap hingga akhir 31 Desember 2024. Jadi cukup banyak regulasi yang sudah dikeluarkan dan memberikan satu kerangka yang penting dalam penerapan sistem digital kesehatan di Indonesia. Bapak Ibu sekalian, saya ingin membahas atau mengangkat satu framework, yaitu Human Organization dan Teknologi, HOTFIT ya. Dan HOT ini diangkat oleh tim oleh Yusuf dan kawan-kawan di tahun 2006, di mana HOT ini mencakup human atau manusia, organization atau organisasi, dan teknologi ya. Di mana model ini merupakan satu framework evaluasi yang banyak kita gunakan, dan ini merupakan kontribusi dari teman-teman di FK-KMK UGM, di mana bekerja sama dengan Forkomtiknas untuk selalu mendorong pendekatan human organization dan teknologi dalam setiap pendekatan sistem informasi kesehatan saat ini. Dan ini sangat membantu kami baik sebagai praktisi maupun sebagai konsultan untuk melihat aspek HOT ini. Nah, apa saja hal-hal yang bisa kita kaitkan
Ahmad,
dengan
waktunya tinggal 4 menit lagi, mohon izin.
Siap. Ya. Saya lewatkan untuk aspek ini. HOTFIT ini bisa digunakan sebagai satu framework. Kemudian framework yang lain yang kita perlu gunakan adalah WHO-ITU National Health Strategy Toolkit. Nah, secara cepat kita coba untuk melihat evaluasi terhadap apa saja yang sudah dilakukan di Indonesia. Ada dua hal yang perlu menjadi perhatian, yaitu strategi dan investment lebih di kalangan fasilitas pelayanan kesehatan. Ini perlu menjadi perhatian. Dan topik yang relevan dibahas pada hari ini yaitu tentang SDM atau workforce. Sedangkan aspek lainnya sudah ada, walaupun tentu tetap ada ruang untuk peningkatan. Nah, berikutnya adalah terkait dengan penilaian kematangan digital. Ini juga merupakan hal yang penting yang perlu digunakan oleh konsultan manajemen kesehatan terkait dengan bagaimana konsultan kesehatan dapat membantu implementasi Satu Sehat. Ya. Ini disediakan oleh Kementerian Kesehatan, jadi setiap fasilitas pelayanan kesehatan dapat menggunakan Digital Maturity Index Assessment ini melalui platform yang sudah disediakan oleh Kementerian Kesehatan dan tidak dipungut biaya. Nah, berikutnya juga terkait dengan bagaimana pemanfaatan penilaian kematangan digital. Tentu ini sangat penting, baik di level fasilitas pelayanan kesehatan, di level subnasional maupun di level nasional. Nah, Bapak Ibu sekalian, apa saja yang kita bisa lihat tentang pentingnya kualitas data di dalam sistem informasi kesehatan. Tentu kita ketahui bersama bahwa kualitas data ini sangat penting karena kita tidak ingin data-data yang dikumpulkan kemudian tidak bisa memberikan atau memberikan hasil yang tidak berguna ya karena kualitas datanya yang tidak baik. Oleh karena itu, kami mendorong pendekatan sistem manajemen mutu ini menjadi satu hal yang penting dalam health data governance. Ya. Nah, inilah kalau kita rangkum dari apa yang sudah saya sampaikan tadi, bahwa WHO National E-Health Strategy Toolkit ini merupakan umbrella ya atau payung dari semua kegiatan yang kita lakukan terkait dengan digital health, di mana kita melihat WHO ITU itu dari aspek human organization dan teknologi, dan kemudian kita melihat juga tentang bagaimana penilaian kematangan digital, kemudian bagaimana data governance, dan juga peta jalan strategi digital kesehatan di setiap tingkatan, ya, mulai dari fasilitas pelayanan kesehatan hingga Kementerian Kesehatan di tingkat nasional. Nah, diharapkan dengan pendekatan ini, konsultan kesehatan, konsultan manajemen kesehatan dapat menggunakan atau membantu implementasi satu sehat tidak hanya di level nasional, baik tapi juga di level subnasional maupun di tingkat Pasienkes. Dan tentunya apa yang kita harapkan adalah satu peningkatan berkelanjutan atau continuous improvement dari pendekatan ini. Nah, dengan adanya pendekatan tersebut, maka peran konsultan manajemen kesehatan ini sangat penting ya untuk bisa mendorong bagaimana implementasi dengan memberikan masukan, tapi juga melakukan evaluasi, ya, juga melakukan uji coba, serta melakukan juga atau mengidentifikasi faktor-faktor kritikal. Tapi juga tidak kalah pentingnya adalah untuk peningkatan SDM dari pelaku yang nanti akan terlibat dalam implementasi satu sehat. Saya sampai pada tahap akhir dari presentasi saya tentang konsultan manajemen kesehatan berperan penting dalam implementasi satu sehat berdasarkan kompetensi dan lingkup kerjanya. Model evaluasi yang komprehensif diperlukan mengintegrasikan aspek teknologi, manusia dan organisasi, data governance, dan strategi digital kesehatan. Hasil penilaian kematangan digital dapat digunakan untuk menentukan strategi implementasi di setiap fasilitas pelayanan kesehatan. Perlu adanya satu memperhatikan rekomendasi WHO secara menyeluruh, serta penerapan health data governance penting dalam implementasi satu sehat. Dan terakhir adalah monitoring dan evaluasi implementasi dan dari konsultan manajemen kesehatan dapat memberikan nilai tambah dalam bagaimana implementasi satu sehat dilakukan. Demikian presentasi yang dapat saya sampaikan pada siang hari ini. Mudah-mudahan bermanfaat dan bisa menjadi pertimbangan dari Bapak Ibu sekalian untuk mendiskusikan lebih lanjut. Sekian, terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Ahmad. Please wait in the Zoom room because we will continue with other speaker, and then at the end we can have discussion sessions. For those in online or in the room, if you have any questions related to the presentation from Dr. Ahmad, please write down in the chat, or probably you can write down in your notes, and then we can discuss after all the speaker provide his presentations. Okay, the next sessions is Dr. Ferry. Dr. Ferry is a provincial health office, and then DKI Jakarta has very good examples of the role of the subnational level in Indonesia to improve the digital health adoptions in subnational levels. Dr. Ferry, are you ready?
Terima kasih, Pak Guru. First of all, I would like to say good afternoon, ladies and gentlemen. And before starting this presentation, I would like to express my gratitude to the organizer, UGM in particular, who have invited us to share our stories with all the experts in this event. Please allow me to deliver the presentation in English. On this occasion, I also will not talk about general things related to the implementation of Satu Sehat because I believe that general things must have been done by other provinces in Indonesia. Therefore, on this occasion, please allow me to present the unique things that are done in Jakarta, particularly in developing and implementing the interoperability layer of antenatal care data in Jakarta as part of Satu Sehat implementation. Next. Before getting into the core of the presentation, let me tell the background of Jakarta, why Jakarta is running fast to digitize its health services, including transforming its organizational structure. Because Jakarta feels the importance of health data and information system, today Jakarta already has new unit that take care of the data and system information with the establishment of Regional Health Data and Information Technology Center, a form of upgrading unit that were previously in the form of section led by Echelon 4 official to Technical Implementation Unit led by Echelon 3 official. I also want to share that to inform that with the issuance of Law Number 3 of 2022 concerning the state capital, where there is a transfer of state capital from Jakarta to IKN, Jakarta will no longer act as the capital city of Indonesia, but Jakarta will still remain as a development priority to continue to be developed as business city, financial city, on a regional and global scale. To be a global city, a city must have this kind of characteristic. And this is what drives Jakarta Provincial Health Office to accelerate its digital transformation, especially in terms of integrating its health data and information system. Next. As a mega city, Jakarta is a very heterogeneous city with various background of its residents, social status, including geographical condition. As we can see in the picture, we have lots of health facilities in Jakarta. We have hundreds of hospitals, thousands of clinics, not to mention health facility which owned by the independent doctor who give a private practice that spread throughout Jakarta. The number of health facilities available is an advantage for Jakarta, but also a challenge, especially in integrating health information system. Next. In order to provide a clear and measurable direction in supporting the transformation of health services in Jakarta, thanks to God, Jakarta already developed a master plan for the transformation of health services, where the purpose statement to be achieved is to make Jakarta as the health epitome, where the use of digital technology is one of its 5 strategic pillars. Next. Now, some of the speaker already mentioned about Satu Sehat. I just want to stress another things about Satu Sehat. Satu Sehat is a FHIR-based national health data exchange platform initiated by the Indonesian Ministry of Health, utilizing global standard and international recognized terminology standards such as ICD, SNOMED, LOIN, etc. Since 2022, late 2022, healthcare facilities in Jakarta have started adopting Satu Sehat as the national FHIR data exchange platform. Next. As we can see here, that Jakarta demand and use health data very widely, but on the other hand, Jakarta is facing several challenges while trying to improve the availability of health data. There are some challenges such as scattered and non-standardized data, a siloed system of cell system and electronic medical records, fragmented healthcare services, and so on that we already talked at the previous session. Next. Here is one of the challenge and burden of documentation example. This is an ANC visit. The diagrams show the documentation burden faced by the healthcare provider for each antenatal care patient visit. As you can see, a single ANC visit requires documentation in 4 information systems and 1 paper-based personal health record. This thing underscoring the complexity and the redundancy in the current data management landscape. This is only from ANC visit, and there are lots and lots of other services that we provide, and they also have this kind of burden with different kind of system, multiple system, and also still have a paper-based recording. So what can we do with all these things? We try here in Jakarta, we try to improve connecting health services through standardization and interoperability in Jakarta by building or by develop the interoperability layer. Thankfully, we are supported by CISU USA to develop interoperability layer, leveraging generic FHIR mediator. And the module that we start as of our pilot project is ANC module. Why we use the ANC module? There are some reasons. The first is because there's WHO digital adaptation kit for antenatal care that already exists, and then the Ministry of Health through DTO already make the Satu Sehat ANC module. They have the playbook already. So because of those things, then we choose ANC as our first interoperability layer module. Here are the Jakarta interoperability layer development scene. So here in Jakarta, we categorize health facility into grades. There is grades 1 that it means that the health facility already implement EMR and can also implement the FHIR. Grade 2 already have EMR but still using a non-FHIR format. There are also the grade 3 and grade 4, but I'm not going to tell you in this occasion because most of the health facility in Jakarta is already in grade 1 and grade 2. So by building this interoperability layer, now we can integrate the health facility to Satu Sehat via interoperability layer in Jakarta. As you can see here, the upper one, health facility grade 1 with FHIR format standard can send the data directly to the Satu Sehat, and then the data that already validated from Satu Sehat will be sent back to the Happy FHIR storage in Jakarta. and then the data will be visualized in our dashboard. But for the health facility that not using FHIR standard yet, but using a local standard, the data will go into the interoperability layer. The data will be will be get the transformation there. So the output will be in FHIR format, then will be sent also to Satu Sehat, and then go back to the Happy FHIR in Jakarta. So by doing this, we can increase more data, more variable data that is sent to the Satu Sehat, and also help the health facility to accelerate their integrity to Satu Sehat. Next. In 2023, we already conduct a survey involving 18 regional hospitals to identify the challenge they encounter during the implementation of Satu Sehat. The challenge related to the adoption of FHIR standards include the needs of modify existing system, gaps in human resources, standard complexities, and the duration required for resource mapping. Next. But by doing this, by building the interoperability layer, not only that we can reduce the line of code, but also we can reduce the development complexity. So it will be much easier for the health facility to integrate with Satu Sehat. Next. Next. Okay. We also already conduct a survey with the EMR developer from hospital on their perspective toward the use of local standard format. Based on their subjective answer, local standard format actually reduce the duration needed for FHIR resource mapping and reduce the standard complexity. But the adjustment are still needed to both front and back end system. Next. Now we are currently in exploration phase, seeking optimal methods to process, analyze, and visualize the data obtained from the healthcare facilities. The dashboard is still in development stage with collaboration between technical teams and health program experts in Jakarta. Next, let's go directly to conclusion. Yeah. So next. So far, what we learned from the development of interoperability layer that has begun since June 2023 is that interoperability layer utilizing Mediator address Satu Sehat adoption challenge by reducing standard complexity and FHIR mapping duration. The use of Mediators potentially improve the amount of data sent to Satu Sehat. We can see from the increased number of FHIR resources from ANC visits to Satu Sehat. The ANC mediators developed in Jakarta can be scaled up to other regions in Indonesia, potentially improve the availability of the mother and child health data nationwide. Thank you.
Yeah, thank you very much, Dr. Ferry. I think this is a very interesting presentations, how the provincial health office facilitate the interoperability that cover many health facility under the province levels, and then in the same time contribute to the Satu Sehat platform that obligations from the by law by the Ministry of Health decree that this year it's expected that all the health facilities should be integrated into the Satu Sehat. Thank you very much, Dr. Ferry, for the presentations. And the next speaker is Pak Purwadi Sujalmo. He is from the hospitals. And please welcome because he is here. I think you can present from here. It's fine. And then may also use Bahasa Indonesia because we have an interpreter as well. Yeah, please.
Thank you, Pak Gugu, Dr. Lutfan. Baik. I will present my presentation using bahasa. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang Bapak Ibu semua. Pada kesempatan kali ini saya ingin sharing berbagi pengalaman mengenai implementasi satu sehat di layanan Fasiankes atau Health Facility. Oke. Nah, sebelumnya saya ingin menceritakan sebuah pengalaman kemarin juga saya share dengan rekan IT mengenai topik ini juga. Memang masih ada kendala, terutama di Jogja mengenai implementasi satu sehat. Selain itu juga belum semua fasilitas kesehatan mampu untuk mengupload data pasien dengan dengan baik. Lalu ya ini juga jadi tantangan tersendiri bagi masing-masing fasilitas kesehatan. Contohnya seperti ini. Dari Bapak Ibu semua, apakah sudah punya aplikasi Satu Sehat? Apakah verified?
Coba dicek yang dulu. Tuan.
Belum. Ada yang belum, ada yang sudah. Pernah mencoba untuk verifikasi Satu Sehatnya? Centang biru kalau nggak salah. Belum? Nah, untuk mengakses data Satu Sehat yang diupload oleh Fasiankes itu harus verified account. Jadi tidak bisa yang belum verified belum bisa. Dan untuk yang melakukan verifikasi itu hanya bisa di Fasiankes tertentu saja. Dan sayangnya juga di salah satu listnya Rumah Sakit Akademik UGM, Academic Hospital itu belum ada di situ listnya. Kalau nggak salah itu baru Sarjito sama Panti Rapih kalau rumah sakit besarnya, sama Bethesda kalau nggak salah. Lainnya klinik juga. Itu. Jadi itu yang pertama yang ingin saya sampaikan. Jadi memang masih apa ya? Kalau Desember disuruh untuk implementasi tanggal 31 Desember saya lihat kok juga belum apa ya? Belum optimal gitu. Next. Nah, jadi kenapa kok perlu Satu Sehat? Saya rasa karena TPRS di Indonesia itu cukup beragam. Ada tipe A, ada tipe B, ada tipe C, lalu juga dengan special hospital kayak rumah sakit ortopedik, rumah sakit ibu dan anak, sehingga fasilitasnya cukup beragam. Dan tiap pasien pasti berkunjung lebih dari satu Fasiankes. Bapak Ibu meskipun orang Jogja, ketika berkunjung ke Jogja, pasti tidak hanya di Sarjito saja. Pasti ke puskesmas, atau ke klinik pribadi, atau ke mana lagi, ke rumah sakit, atau ke ya dan sebagainya, atau ke dokter gigi. Nah, dokter gigi ada sendiri, klinik pribadi, dokter umum ada sendiri, sehingga datanya tersebar. Satu pasien itu datanya tersebar dan ketika misal saya sebagai perawat gitu, lalu ada pasien yang sudah kronis kondisinya, stroke, dan dia cukup lama dirawat di rumah sakit sebelumnya. Kemarin saya mendapat pasien itu tumor servikal. Jadi tumor servikal sudah 5 kali operasi di Sarjito. Tapi begitu yang terakhir kambuh karena datang ke rumah sakit akademik karena henti jantung, habis itu masuk ke ICU. Tapi untuk mencari datanya, 5 operasi itu bagaimana kondisinya, itu sangat susah. Bahkan kita tanya ke keluarganya pun juga cukup sulit. Gitu. Sehingga ini jadi tantangan untuk pasien-pasien misal kalau nanti sudah ke layanan paliatif sudah sangat maju atau layanan home care sudah sangat maju, jadi perawat-perawat yang atau dokter tenaga medis yang ada di layanan home care atau layanan tahap akhir bisa mengetahui riwayat pasien dengan cukup komprehensif. Nah, ini beberapa Fasiankes juga sudah menerapkan electronic medical record. Kemarin 3 bulan lalu itu istri saya baru lahiran, terus juga dirawat di rumah sakit yang cukup mungkin tipe D apa tipe C ya, itu di Sakinah Idaman. Nah, terus ketika lahir di sana, hampir semua prosesnya menggunakan EMR, bahkan menggunakan untuk inform consent pun pakai tanda tangan elektronik, pakai Wattpad gitu. Nah, cuman memang agak jadi, habis itu saya diskusikan sama tim IT, boleh nggak inform consent pakai Wattpad gitu, pakai sign elektronik gitu, ataukah harus yang kan kalau di dokumen-dokumen resmi harus ada barcode resmi yang dikeluarkan sama elektronik itu ya apa? Ya itu seperti itu, semacam itu. Apakah ini bisa dipakai atau tidak? Nah, itu jadi diskusi saya kemarin juga sama tim IT. Itu sehingga memang penerapannya pun berbeda-beda. Penerapannya EMR-nya itu tahapannya pun juga berbeda-beda. Nah, harapannya nanti transformasi EMR ini bisa data menjadi lebih komprehensif dan terintegrasi. Next. Oke. Nah, ini tadi sudah disebutkan sama dua pembicara sebelumnya bahwasanya pada akhir Desember EMR wajib digunakan di seluruh rumah sakit di Indonesia. Lalu pada tahun 2002 Persi melakukan survei bahwasanya masih ada 44% rumah sakit yang belum menggunakan SIM RS. Nah, kendala ini cukup beragam. Tadi sudah juga disampaikan ada human, ada organization, ada IT-nya juga, fix IT-nya juga. Nah, ini kendala-kendala di masing variabel itu juga masih terjadi di rumah sakit terutama di yang rural area atau rumah sakit terpencil, RSUD itu. Apalagi ada salah satu rumah sakit besar juga ketika menggunakan EMR yang input datanya itu perawat junior, perawat seniornya nggak mau input data. Ini kan jadi beban perawat juniornya buat input data pasien. Misal pasien satu bangsal 25, yang jaga cuma 2, yang junior 1. Nah, ini yang junior input data semua kan agak berat. Itu untuk faktor human saja. Itu. Nah, Satu Sehat nanti ini harapannya bisa menaungi lebih dari 400 aplikasi EMR di Fasiankes tersebut. Nah, di Satu Sehat itu ada fungsi berupa surveillance kesehatan, lalu ada penyelenggara, kita mengetahui pelayanan kesehatan yang kita gunakan, lalu juga ada layanan informasi kesehatan di Satu Sehat. Kalau Bapak Ibu buka Satu Sehat, ada edukasi kesehatan di situ, ada bagaimana melakukan aktivitas kegiatan olahraga yang baik, itu juga ada di situ. Dan berbagai informasi lainnya tentang kesehatan, edukasi kesehatan yang bersifat promotif, preventif, kuratif, dan rehabilitatif ada di Satu Sehat. Lanjut. Nah, data yang diinput di Satu Sehat itu ketika saya diskusi dengan tim IT ada berupa data pribadi, ada nama, jenis kelamin, tinggi badan, berat badan. Nah, jadi data ini bersifat pribadi, habis itu mungkin tanggal lahir juga, habis itu usia dan sebagainya itu data pribadi, lalu data geolocation. Nah, jadi di Satu Kesehatan dia pakai kita bisa mengetahui saat kita membuka akses Satu Sehat, maka server akan mengetahui di mana Satu Sehat itu akan dibuka. Itu. Dulu pas awal-awal Peduli Lindungi yang pakai iPhone sempat datanya terkuras habis karena data geolocation ini berjalan di background. Nah, tapi setelah diupdate hanya berjalan ketika itu digunakan. Lalu data Satu Sehat juga mengambil data dari fasilitas pelayanan kesehatan. Kalau dulu ketika di Peduli Lindungi hanya mengambil data vaksin COVID, saat ini fasilitas pelayanan kesehatan bisa menginput data rekam medis elektronik, riwayat kunjungan. Maaf kalau di ICU keseringan baca RS, keseringan ngomong elektrolit, jadi ke elektronik. Cek elektrolit, elektronik. Imunisasi, vaksinasi, dan informasi lainnya. Jadi bisa diinput di Satu Sehat oleh fasilitas pelayanan kesehatan. Cuman ini yang jadi memang tadi interoperability-nya. Jadi misal dari apa yang digunakan di rumah sakit itu pakai kode A, lalu diupload ke Satu Sehat, nah itu butuh usaha juga. Nah, di pasal 28 di Permenkes 24 tahun 2022, bahwasanya fasilitas pelayanan kesehatan wajib mengirimkan dan membuka akses rekam data medis kepada Kementerian Kesehatan melalui platform Satu Sehat tersebut itu. Sehingga memang nantinya Fasiankes itu wajib mengupload semua data-data tersebut di dalam aplikasi atau platform Satu Sehat melalui apps atau melalui websitenya. Lanjut. Nah, ini untuk pemanfaatan Satu Sehat di Fasiankes untuk saat ini yang bisa dinikmati, mungkin yang bisa kita akses sebagai pasien atau sebagai tenaga kesehatan. Pertama, riwayat vaksinasi dan imunisasi. Vaksinasi terutama yang masih bisa saya akses COVID. Tapi kalau vaksin, saya kebetulan misal lahiran tahun 90 gitu, pengen tahu udah pernah vaksin apa vaksin DPT atau belum ya nggak bisa masuk di situ. Nah, tapi nanti yang sudah ketika satu saat itu di apa di upgrade terus anak anak-anak yang lahir di tahun 2023 nanti akan ada riwayat vaksinasi dan imunisasi. Lalu pendaftaran Fasiankes dan klinik. Nah, di Satu Sehat itu juga ada, kita bisa memilih mau ke Fasiankes mana. Tadi juga disampaikan harapannya nanti Satu Sehat akan bisa terhubung dengan BPJS. Nah, jadi nanti kalau misal saya BPJS-nya Sleman, regional Sleman, Puskesmas Melati 1, maka ada pilihannya mungkin. Nanti saya bisa dirujuk kemana saja di Satu Sehat itu. Nah, tadi juga pasien menginputkan data dasar dan hasil pemeriksaan pasien. Ini juga harapannya sih bisa ini ya, bisa secara nasional. Kebetulan ini saya punya pengalaman kemarin Bapak Ibu saya bawa ke Jogja untuk pemeriksaan MCU. Setelah MCU ada rekomendasi dari dokter jantung untuk melakukan pemeriksaan A untuk lanjutannya. Misal contohnya apa ya? Pemeriksaan cath lab untuk memastikan jantungnya sehat. Tapi begitu dibawa ke tempat asal Bapak Ibu saya di Jombang, lalu dikonsulkan apakah bisa dilakukan pemeriksaan PCI, ternyata dari dokter yang di Jombang bilang, udah terapi konvensional aja. Jadi nggak nyambung antara rekomendasi yang ada di Prof. Ghufron. Iya, jadi itu tadi. Jadi saya lanjutkan. Selamat datang Prof. Ghufron. Prof. Yodi. Oh, pemeriksaan jadi tidak berlanjut atau tidak ada keberlanjutan antara pemeriksaan yang ada di Jogja dan yang ada di Jombang, sehingga itu jadi tantangan ke depannya, harapannya layanannya itu bisa terintegrasi dari informasi yang sama. Lanjut. Nah, keuntungannya Satu Sehat tadi saya rangkum ya, keuntungannya meningkatkan aksesibilitas informasi dan data pasien, meningkatkan keselamatan pasien juga, lalu mengefektifkan biaya atau kos sehingga pemeriksaan yang sudah dilakukan tidak perlu diperiksa ulang, lalu juga bisa menjadi landasan penelitian dan kebijakan. Jadi kalau di kemarin saya berbicara mengenai early warning system di Indonesia, kalau di UK itu warning systemnya sudah berlaku secara nasional. Ketika early warning system itu berlaku secara nasional, National Health System atau NHS itu bisa melakukan penelitian terhadap sistem tersebut di masing-masing Fasiankes. Nah, ini jadi apa ya? Jadi menarik gitu. Lalu meningkat kualitas perawatan juga seperti yang saya ceritakan tadi mengenai pasien yang sudah terminal atau sudah paliatif sehingga kualitas perawatan kita menjadi lebih maksimal. Dan keuntungannya di Satu Sehat itu yang saya baca, data akan bertahan selama 25 tahun sejak akses atau penggunaan terakhir dan akan tetap disimpan apabila nanti dibutuhkan. Nah, ini jadi datanya jadi lebih lama dan lebih aman gitu dan bisa diakses dengan mudah. Selanjutnya. Nah, tantangan dan kelemahannya tadi juga sudah disampaikan bahwasanya butuh upaya untuk sustain atau berkelanjutan dan terus dikembangkan. Jangan sampai program Satu Sehat ini hanya berhenti kalau sudah pemimpinannya ganti nanti berubah lagi. Nah, sehingga mengulang dari awal dan infrastruktur juga berbeda lagi. Itu harus dikembangkan semua di masing-masing rumah sakit dan masyarakat harus terinformasi, punya digital literasi yang cukup bagus. Kayak tadi misal Satu Sehat, yaitu disosialisasikan kalau harus verifikasi Satu Sehatnya dan centang biru di aplikasi Satu Sehatnya. Nah, tadi mengendalikan atau faktor HOT tadi ya, Human Organization dan Teknologi untuk mencapai pemanfaatan yang optimal dan kerahasiaan data pasien itu harus dijamin keamanannya. Ini juga hal yang penting dan tidak bisa kita abaikan. Lanjut. Simpulan, ya implementasi Satu Sehat menurut saya pribadi sampai saat ini masih belum 100% sesuai dengan harapan yang telah dicanangkan. Nah, ini mungkin kendalanya adalah beragamnya aplikasi EMR dan beragamnya kondisi Fasiankes di negara Indonesia yang cukup luas, lalu evaluasi penerapan satu sehat sebagai data dasar dan perbaikan implementasi mendatang. Ini sangat penting karena saya coba mencari di Google Scholar, saya coba mencari di Science Direct, itu belum ada penelitian yang terpublish mengenai evaluasi satu sehat ini. Nah, harapannya nanti ada satu penelitian bagaimana untuk evaluasi atau menilai atau untuk memberikan rekomendasi satu sehat nanti bisa dikembangkan ke arah mana. Saja yang bisa saya sampaikan. Terima kasih atas kesempatannya. Kurang lebihnya mohon maaf. Selamat siang. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Ya, terima kasih Pak Purwadi Jalmo. Yeah, welcome, Prof. Ghufron, to the Faculty of Medicine and Public Health and Things. And we have discussed three presenters previously. One from the Dr. Ahmad Hidayat from the Technical Working Group of Sehat. He speak about the importance of the health consultants, to improve the digital innovations in Indonesia. And the second presenter, Dr. Ferry, is from the DKI Jakarta Provincial Health Office. His presentation related to the role of the Provincial Health Office to facilitate the digital adoption in health facilities, especially under the Provincial Health Office. And the third, Purwadi Sujamo, he is from the UGM Academic Hospital, and he just present about the important and the challenge of adoption of digital health in hospitals. And I think it is your turns, Professor Gu, to provide the presentations to all of us about the experience of the BPJS Kesehatan to facilitate the telemedicines in Indonesia. We know that one of the issues in Indonesia, we have more than 60,000 health facilities, and we have more than 500 district health office, and well, lots of technologies, digital technology has been adopted in Indonesia. And I'm sure that Prof. Ghufron will provide us insight about the implementation of the digital health that facilitated by the BPJS Kesehatan, because since 2014, the accelerations since the BPJS implement runs in 2014, the acceleration of digital health is very high in Indonesia, and then many innovation that already developed by the BPJS Kesehatan. Please, Profesor Ali Ghufron Mukti.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Yang kami hormati Bapak Deka, tentu yang luar biasa, dan selamat atas profesornya. Tepuk tangan untuk Pak Dekan kita. Dan juga panelis kita yang datang dari jauh, serta Pak Ahmad Hidayat, ya saya lihat di online, dan dan Dr. Ferry Adian, serta Mas Perwati yang barusan, dan tentu Pak Lutfan dan Mas Gugu, dan semuanya saja. Ini kami didampingi Bu Dwi yang istilahnya kalau di pemerintahan itu ada gubernur, beliau gubernur tapi dua provinsi, Jawa Tengah dan DIY gitu. Dan teman kita yang bertanggung jawab di Sleman itu Dr. Nandar. Baik, ini Pak Ahmad Hidayat yang mewakili dari BPJS dari apa namanya Satu Sehat di Kementerian Kesehatan, dan tadi sudah oke. Kita bahasa Inggris atau bahasa Indonesia?
Bisa bahasa Indonesia karena ada interpreter juga.
Oh ya, oke. Kalau gitu bahasa Indonesia saja. Jadi ada slide-nya tadi kok udah pergi. Baik, jadi sebetulnya BPJS itu memang benar apa yang sampaikan Pak Gugu tadi, digital e-health itu menjadi satu enabler dan accelerator yang luar biasa mempercepat itu, sehingga sistem kita tadi yang diceritakan Mas Perwadi tadi, apa yang terjadi di Inggris dan juga di Satu Sehat itu di BPJS itu memang sudah dilaksanakan gitu di banyak hal. Berikutnya, jadi tadi yang ya apa itu jatuh. Baik, berikutnya slide. Nah, ini saya kira nggak perlu kita jelaskan Indonesia at glance, ya. Karena kita memang terdiri dari 17.000 pulau dan lainnya. Berikutnya, iya, ini peserta penduduk kita itu 277 juta. Terus sekarang pesertaannya kalau dulu 140, pokoknya udah tak apalkan 265 jadi 266. Dan kita sudah payment point channel, ya, itu ada OVO, ada ini segala macam itu udah hampir 1 juta. Kalau saya ngomong 10 aja sulit, Pak. Bayar pakai Indomaret, pakai OVO, pakai GoPay, pakai Bangga. Ini baru 4 ini. Itu nyebut 10 sulit. Ini sekarang sudah hampir 1 juta, 960.000 lebih channel pembayaran. Dan keuangan sendiri bingung lah. Kalau dulu namanya collection rate, ya, itu nggak pernah sampai 65%. Sekarang ini 90% lebih. Jadi pada heran ya. Kalau di Inggris ini yang dari Inggris ada nggak? Kemarin dijemput saya ketemu.
Tuan Lee, from the Middlesex University.
Oh yeah, from
Middlesex
University. Oh, Middlesex. So in UK, for example, there is no collection of the premium because they just cut from the tax because tax-based system. In Indonesia, we have to collect the premium, and the collection rate now is more than 90%. When I was in UK, just gave a lecture in Oxford, then one of the prominent person in that Oxford is the parliamentary member, and she asked me, well, so you can collect the money from the population? Yes, now is the collection rate more than 90%. Whoa! So you should now work in UK, and I hope that your payment, your salary is more than you work in Indonesia. He said, let's see. And no, I said, so it's better to work in Indonesia. I said, okay, lanjut ya. Because there is no collection rate, Pak. Di sana nggak ada itu. Karena jangan kayak PBI di Indonesia tuh, Pak. Kalau PBI pun kita harus koordinasi pemerintah pusat dan pemerintah daerah. Nah, kalau di Prancis itu, Pak, melayaninya 70 juta. Pekerjanya 85.000. Di BPJS ya melayaninya 270 juta. Pekerjanya 8.500. Kalau di sana 85.000, BPJS ini temannya Bu Dwi ini 8.500 yang. Jadi saya waktu masuk itu FTA full time equivalent 1,2. Sekarang akhirnya di perjalanan kita 2 orang terus 1,5, sekarang sudah 1,8. Artinya seperti Pak Nandar ini 1 orang kerjanya hampir sama dengan 2 orang, tapi gajinya 1 orang. Berikutnya, tapi tahun ini kita dapat kenaikan akhirnya. Nah, ini data center, Pak. Enggak ada suaranya.
Command Center Data Center BPJS Kesehatan beroperasi selama 7x24 jam yang berfungsi untuk mendukung ketersediaan sistem TI sesuai target sebesar 99,99%, sehingga proses monitoring Command Center Data Center BPJS Kesehatan memiliki peran yang vital dan kritikal terhadap keberlangsungan SIM BPJS Kesehatan.
Udah, berikutnya. Jadi ini yang diterangkan Mas Perwadi tadi. Kalau di sini ya memang dijelaskan, dijalanin. Yang dia dibayangkan, jelaskan. Nah, kalau di sini dijalanin. Gitu. Nah, Pak M.Kes karena belum pernah melihat, nah ini beberapa waktu lalu baru melihat dan beliau sangat apresiasi. Terus ya. Kok enggak ada? Suaranya emang gini ya? Oh, kelihatannya ininya apa kabelnya itu enggak atau belum dimasukkan, belum connect. Betul. Oke, terusnya. Jadi kita ada namanya convention forum. Itu banyak yang belum tahu bahwa ini dari berbagai negara ya sekarang itu pada lihat, pada surprise karena kita real data ratusan juta. Kalau di UK mungkin nanti di Middlesex bisa cerita ya kira-kira berapa juta data, real time, and this is about more than 100 million data. So, and real time. So we can monitor when Pak Perwati mentioned about how actually the behavior of hospital or clinic that they can monitor, we can do it in BPJS Kesehatan. Even who actually tend to committed to fraud, we also have information on that, and we can, Zoom. And there is many from countries visiting the BPJS Kesehatan in care center. Kalau saya yakin Mas Gugu belum pernah itu, San. Belum pernah itu. Oh, kalau Pak Dekan kita undang, Pak. Kapan ada waktu nanti untuk melihat, karena banyak orang nggak tahu. Ya, diketahui Bank Dunia ini Pak Ahmad tadi yang masih mengikuti kan di online, yang membantu M.Kes, mereka datang lihat BPJS itu terheran sendiri gitu. Dan WA kita. Berikutnya. Ya, terus suaranya ya. Nah, ini
I think Indonesia's experience with JKN has not only been aspirational, but it's also been inspirational to a lot of countries which come from the same context, lower middle income countries that are aiming to achieve universal health coverage.
And then also coming to see the command center, I found the command center also something that is remarkable for me, that it helps you to get a feel of what is happening on the ground, and then how it is being used also to drive enrollment and all. I think I'm highly impressed.
I congratulate everyone who's worked on BPJS. It's amazing to see the level of coverage across the country and to see the attention to equity and meeting the needs of the population.
The integration between levels of the health system and from providers to BPJS is something that's really stood out. So the way that the technology has been used and information is shared to provide better care for the population is something that's been really impressive, and I'm excited to learn more about it.
So I was very impressed by how efficient the leadership, how efficient the management of everything was.
BPJS keren.
Masa orang Amerika mau bilang BPJS keren ini bisa bahasa Indonesia. Berikutnya, jadi kita tidak hanya mengembangkan telemedicine, tetapi termasuk teleconsultation. Kalau dulu itu orang bicara BPJS itu butuh kalau sakit ya, just only when they are got sick, so thinking about BPJS Kesehatan. But now no, even they are healthy, they can have teleconsultation with us, and they can have like screening program and many things. Jadi yang kedua mengenai biometric fingerprint ya, sekarang kita ngecek itu, cuma memang beberapa itu komplain jadi agak antri agak lambat kan. Nah, ini sebetulnya di encourage tapi tidak harus kalau untuk dalam keadaan tertentu. Jadi kayak cuci darah itu biasanya sulit ya. Termasuk elektronik SIP, integrated queuing system. Ya. Itu bayangkan Pak, waktu kita baru dilantik itu langsung ya ada congratulation, tetapi banyak juga yang protes gitu Pak Dekan. Protesnya itu, wah saya gara-gara peserta BPJS kami harus menunggu 6 jam. Saya sampaikan sebentar. Dilantik saja belum, Anda sudah protes. Ya. Kita ya dilantik dulu baru kerja gitu. Terus kita bikin queuing system sekarang estimate in average itu 0.5 hours. And actually when they are using the queuing system and they can queue from home and they will know what time the services will be given. So they know exactly, so they can measure and estimate time needed from their home go to the health facilities. Jadi ini sangat memudahkan. Bed availability, surgery schedule, just to ask you whether it is correct or not. When we read in UK, and now some of the health manpower are striking. Oh yeah. Yeah, the queuing system. Right. Yeah. And for the surgery, but not emergency, elective surgery, they have to wait approximately something like 40 weeks or something like that. So yeah, but in Indonesia should be less than 4 weeks. If more than 6 weeks, more than 1 month, many people will shout and complain, maybe report to the president. Okay, next slide. Yeah, next slide. Yes, yeah, this is the membership. This is the payment system that I mentioned already, more than 900,000. Next slide. So there are many type of channel to pay. So therefore we have a very good collection now. It is integrated queuing system, and only around 87% of the hospital. Just to know, in Indonesia, the hospital is not only a public hospital, but private hospital. In fact, in the reality, 64% of all hospital contracted with BPJS is private. So 64%. Next slide. Yeah. So this is mobile JKN. There are too many characteristics. For example, number 1, a new member registration. So if you would like to register through just online, very easy. Even the pay letter program, doctors, operators, and then I would like to talk to Pak Ahmad Hidayat, who are in the online from Satu Sehat, ya. Tentu ke Pak Purwa juga. Di BPJS, we already developed what we call it the medical record in the hand of the patient. I'm not sure that in UK you already developed that. So each individual who are using the medical record in the hand of the patient. So from Jogja, for example, we call it eye care JKN. So if they, in Jogja, then they move or maybe just have traveled to Jakarta and got sick, go to the hospital. And because we consider that the information is belong to the patient, and if patient then have some concern to the doctors or hospital in Jakarta, then the doctor will know what type of diseases, what type of diagnosis, health facilities, medicine, and allergic of the drug, certain drug, they know. So I'm not sure in UK you already developed, for the whole country. Yeah, so this is very good then. Yeah, but in US it is not the whole country, but only, for example, like in Mayo Clinic and University of Washington, like in the university, but outside university, not over there. But BPJS are now doing and already implementing. Next slide, please. Ya, ini e-health record on mobile JKN. Berikutnya. Yeah. So now we have a quality transformation. And this quality transformation, because previously, if the member of JKN, and they know this member of JKN, then from the hospital will say, okay, the bed is full, so no rooms for you. And if you are hospitalized, maximum days you have to go home, something like that. That is previously, but now we have quality transformation, service quality transformation with only 3 indicators: more convenient, fast, and equity, or non-discrimination. Of course, when we are about the quality according to Donapedian concept, or maybe Edward Deming, or many things. Too complicated, but in Indonesia it's just three for BPJS: convenient, fast, and equity. Next slide. Convenient meaning, so now we no need photocopy. Just use national national identity number atau KTP. It is enough. Just go to every hospital who contracted, and almost all hospital now is contracted with BPJS, but not yet all, but almost all. Next slide. Yeah. So this is the JKN healthcare ecosystem. So JKN integrated care. So we have, you know, with the ecosystem, with members, then with the money, and also with health facilities, we call it HAFIS atau HFIS, Health Facility Information System. Dan kita sudah mengembangkan namanya semacam ini Pak Dekan. Jadi kalau investor mau mengembangkan, dia tahu kita kerja dengan Lapan, dia mau invest itu di mana gitu. Nah ini kalau tadi yang satu sehat orang belum tahu, BPJS lebih banyak lagi yang belum tahu. Itu lebih banyak daripada satu sehat, karena satu sehat kan suaranya lebih dan lebih didengar ya. Tapi kalau BPJS ini kurang ya, lebih banyak yang tidak tahu. Dan kita sudah mengembangkan itu. So if investor would like to invest in which location should be recommended, so we have that type of map. So we are developing that. Next slide. So ini provider contract ya, health facilities, planning contract, ada planning, monitoring. Ini for example in Bandung, one of the hospital, if the patient of BPJS come, so they will cater this patient and give services to the patient in the what you call it, in the basement without air condition, and the same area with parking area. So you can imagine very hot. And I said to our staff, so please remind the hospital within 2 months, you should improve and not discriminate BPJS patient. What happened after 2 months? Everything is very good. And I came to that hospital and interviewed the patient. The patient are very happy, satisfied, and also the managers. So within 2 months. And it was in the hospital like that in the past meaning less than 3 years ago. So something like 3 years, 2 years ago. But now still some, but already changes. Okay, next slide. Yeah, this is the health facility information system. So we know exactly this hospital, for example, this clinic, how many doctors are working there, whether the doctors permission expired or not, and how many beds do you have, or thing like that, and what type of center of excellence, for example, they have what you call it, like cat lab or anything. Next slide. Yeah, this is the peak care application. So in Indonesia now, the number of COVID is increasing again. And this is a problem, of course. But that time when we were, competing with many people infected by by COVID and then died, we have to develop the system to vaccinate our population. The problem is we that time confused and would like to contract with UNICEF. You can imagine if UNICEF contract with UNICEF, they need to develop the application system and then need to socialize how to use it. But in the same time, many people die. Then suddenly they decided that they have to use PCare. So PCare is developed by our colleague in BPJS Kesehatan. I know this because of the World Bank, and the World Bank says, so Indonesians are very lucky you have PCare. You can imagine PCare already used by more than 23,000 health facilities, and they're connected each other and report. So they're able to identify who need to be vaccinated, something like that. Next slide. Ya, ini mengenai digital health, ya tadi sudah. Berikutnya, ini telemedicine termasuk innovation. Next slide. If I would like talk one by one is too many. So this is the eye care JKN, as I mentioned, the medical record in the hand of the patient. Next slide. But doctors, because I check already in the many hospitals, they are feel very, beneficial, and yeah, it is really helpful because they know exactly 1 year record of each patient. Next slide. Yeah, this is the open data, and we just launched a data sample dari mahasiswa atau S2, S3, ya termasuk S1. Ini Pak Lutfan kalau ada bimbingannya, biasanya masalah di perguruan tinggi itu untuk mahasiswa S2, S3, masalahnya itu nggak punya masalah. Belum ketemu ya. Padahal kalau di BPJS itu penuh masalah. Antara lain datanya ini kita sekarang sudah lebih dari 52 juta data sampel untuk bisa dianalisis. Ya. Silahkan analisis, ya, gratis, nggak usah pusing-pusing ngumpulin data gitu. Berikutnya, ya, ini caranya nih untuk data sampel. Nah, ini overview data sampel sudah tadi saya bilang tuh sudah bahkan tidak hanya 42, 57 tapi 82. Berikutnya. Jadi banyak sekali data sampel yang bisa dianalisis. Bahkan yang menarik ini Pak Dekan, kalau Pak Dekan tertariknya kan banyak di tropical disease, di ini kan infectious. Yang ini bisa kita itu ada data namanya longitudinal study ya, longitudinal yang follow up gitu untuk maternal and child health. Dan lengkap datanya. Termasuk yang terakhir ini adalah data TB. Untuk diketahui TB sekarang itu Indonesia nomor 2 di dunia, dan yang meninggal karena TB lebih banyak daripada COVID. Gitu. Kalau COVID semua ikut terlibat, tapi demikian TB. Maka kita dengan sekarang strategic purchasing mencoba bagaimana ikut mengatasi TB. Berikutnya. Nah ini dashboard ya. Apapun kita bisa tahu. Umpamanya the district. If from district we will know how many people already registered and what type of diseases frequently appear in that district. For example, HIV or whatever, and then we know exactly how much money actually spent. And not only that, but it depends. So, for example, we have diabetes mellitus type 1. So how many of the patient suffered in that district, and we give the data dashboard not only to the district but to the ministries who need the data and to the university if they need it. Right. Ya, terus award ini recognition ini terlalu banyak. Ini baru kemarin kami terima dari Wapres ya. Berikutnya. Tapi hampir tiap 2. Ini yang menarik yang ISA. Ya, ISA is International Social Security Association. And nggak ada suaranya ya?
Yes, and now the winner can be announced. So I would like once again to congratulate all member institutions who took part in the competition. It was impressive to see the range and scope of the submissions. The one award we have not yet announced is, of course, the overall winner. So, from 168 entries in the jury had to select one that was outstanding and deserved to be awarded as the winner of the competition. So it is my great pleasure to announce the winner of the ISA Good Practice Award for Asia and the Pacific for 2021. The winner is the Social Security Administering Body for Health, BPJS Kesehatan, Indonesia, for its National Health Security Program.
Ya, ini good practice ya, Good Practice Award kompetisi untuk se-Asia Pasifik yang diberikan tahun lalu 2022 for the performance of 2021. Nah, BPJS dianggap terbaik se-Asia Pasifik gitu. Berikutnya, nah terus jangan yang tadi. Oh ya, thank you. Terima kasih yang tak tunggu-tunggu akhirnya.
Baik,
So
terima kasih.
actually in Indonesia, one more. People usually from abroad or maybe from WHO from cannot differentiate between BPJS or JKN program and the task responsibility of Minister of Health, meaning that about the infrastructure, then process and outcome of health, and the BPJS. So they cannot differentiate. So that is usually we lack of the infrastructure. You know, this number of specialists, number of health personnel, things like that. And of course, also the outcome of the process of health. So in fact, you know, when we are talking about supply side, this is the responsibility of the Ministry of Health. When we are talking about demand side, this is responsibility, not all, only personal health, responsibility of BPJS Kesehatan. For the public health, there is responsibility in the central level, Ministry of Health, but in the local government, responsibility of the usually district office, something like that. So these people are always mixed up. They cannot differentiate. So if it is not good, it is BPJS Kesehatan. Oh, and okay, then I think thank you, Pak.
Thank you very much,
Terima
Prof.
kasih.
Ali Ghufron. Let's applause our speaker. And I would like to invite Pak Purwadi Sujalmo to in front to have discussion sessions, and also Pak Dr. Ahmad Hidayat and also Dr. Ferry. And yeah, thank you, Professor. And I would like to invite audience to ask the questions to our speakers. Is there anyone who like to start? Bahasa Indonesia juga boleh, betul Prof. Tadi juga saya nggak sadar, tadi bahasa Indonesia tiba-tiba. Bisa dalam bahasa Indonesia karena kita ada interpreter, tidak salah. Apakah ada yang ingin bertanya lebih dulu? Memulai? Ya, Dr. Lutfan. Silakan, Dr. Lutfan.
Ya, terkait data sampel tadi, Prof. Ghufron, kami sebenarnya sangat tertarik juga untuk bisa memanfaatkan dengan maksimal. Terus kemudian juga ingin mencoba mengaplikasikan digital twin yang di sesi tadi pagi baru didiskusikan. Nah, barangkali kalau ada isu-isu yang mungkin spesifik ada prioritasnya di BPJS itu kalau ada mungkin bisa menjadi pertimbangan juga untuk mencoba mengaplikasikan dengan konsep digital twin. Ya, mungkin itu. Terima kasih.
Ini bagus sekali, terima kasih Pak Lutfan. Jadi memang terjadi satu gap ya. Banyak sekali orang Indonesia yang dapat beasiswa dari LPDP, lalu dia belajar di luar negeri. Ya. Nah, masalahnya yang bimbing nggak tahu persis BPJS ya. Yang dibimbing ya untuk dapat S3 itu penelitian tentang BPJS dibiayai negara ya. Kemudian setelah menganalisis selesai, dia juga tidak lapor BPJS, BPJS juga nggak tahu gitu. Selesai, tapi dapat skor lumayan kan gitu. Nah, pertanyaan dari Pak Lutfan, kalau kemudian tahu apa sebetulnya yang menjadi prioritas masalah, nah bisa nggak dengan twin model sistem ini kemudian digarap? Ya, tentu itu luar biasa karena BPJS akan terbantu. Nah, saya sampaikan dari linkage seperti ini antara perguruan tinggi, BPJS dan lain sebagainya ini harus lebih bagusnya. Antara lain ini sebagai contoh. BPJS itu sudah mengimplementasikan dan menguji telemedicine itu sudah 3 tahunan ini ya. Tetapi sampai sekarang jumlah rumah sakit yang ikut hampir sama terus, yaitu 117. Kemudian FKTP-nya, yaitu ada yang dari remote area dan juga ada yang tidak, itu juga 50 FKTP atau layanan primer lah gitu. Nah, bayangkan ini salah satunya. Kalau kemudian mau di model dengan Twin ini, itu akan sangat bagus ya. Jadi, tapi sebetulnya masalah dari telemedicine di Indonesia ini adalah masalah koneksi, Pak. Ya, selain masalah-masalah kecil-kecil yang lain, tetapi koneksi itu pemerintah harus bikin namanya BTS ya, untuk bisa koneksi. Dan sudah anggarkan triliunan ya BTS, cuman nggak jadi. Ini nggak usah diterusin.
Jangan tanya alasannya. Jangan tanya alasannya.
Udah tahu ini. Nggak jadi, itu ada ceritanya. Jadi itu Pak masalahnya. Nah, tetapi tidak hanya telemedicine. Contoh umpamanya, kita sekarang kan sudah ada dengan riwayat screening ya. Di Malaysia masih struggling ya untuk screening menggunakan mobile JKN atau menggunakan istilahnya ya antara lain mobile JKN. Riwayat kesehatan, jadi screening riwayat kesehatan. Itu ada sekitar 42 atau 46 pertanyaan. Tetapi yang untuk masalah lain ya, terutama untuk generasi milenial ya, yang sekarang itu mudah sekali stres ya. Nah, itu belum ada. Nah, apakah dengan Twin ini kita bisa mengidentifikasi berbagai masalah kesehatan di masyarakat untuk kita kembangkan bersama sehingga masyarakat nanti tinggal ngisi. Nah, terus teridentifikasi baru ya. Kemudian kita dorong untuk dia periksa selanjutnya. Nah, sekarang yang sering yang kita yang ini tuh untuk DM sama hipertensi ya. Itu prosedur kita ada rujuk balik tapi bisa di screening. Nah, kalau kita masuk ke berbagai macam penyakit-penyakit yang sering atau diduga dilayani, kan ini awalnya dari Kemenkes menginginkan screening setiap anak lahir itu di screen untuk tiroid. Anda bisa bayangkan berapa biayanya ya, untuk screening. Maka BPJS mengembangkan tidak langsung dulu. Jadi kita screening namanya riwayat screening. Jadi diisi dan tidak semua, saya tidak yakin semua di sini tahu dan mengisi ya karena sekarang baru 23 juta orang yang oh anaknya screening. Oh iya. Ini Mas Purwadi yang tahu ya, tapi kan Mas Purwadi memang orang kesehatan ya. Tidak banyak ini masyarakat, jangankan orang kesehatan, Pak. Ya, orang yang ya orang yang harusnya mengerti aja nggak mengerti banyak gitu. Jadi gitu Pak, itu saya contohkan 2 tadi. Ya, masih banyak lagi hal yang kita bisa kerjasamakan. Demikian.
Ya baik, terima kasih Prof.
Kalau nggak ada yang nanya, saya mau nanya, mau tak kasih hadiah.
Wah. Tapi sebelum Ghufron mungkin satu ini Prof Ghufron, mungkin kita tanya dengan ini ada Dr. Ahmad, lalu kemudian ada Dr. Ferry. Sebenarnya kan ada Satu Sehat, lalu kemudian ada BPJS ini Prof. Jadi kalau sebagai konsultan itu Dr. Ahmad tadi kan tentang bagaimana peran konsultan ya untuk memfasilitasi adopsi.
Satu aja, jangan lupa dibayar.
Iya. Nah, jadi gimana Dokter Ahmad? Apakah konsultan itu harus tahu dua-duanya gitu? Jadi Satu Sehat harus tahu, lalu kemudian BPJS tadi yang seperti yang dipresentasikan Prof. Ghufron itu juga harus menguasai supaya nanti bisa memberikan masukan kepada yang dikonsultasikan gitu.
Ya, berarti saya memenuhi syarat Pak.
Wah.
Karena saya tahu BPJS, saya tahu sehat Pak.
Tapi nggak bisa bayar kita Pak.
Oh,
nggak kuat bayar.
Yang kedua untuk Dr. Ferry, ini Dr. Ferry kan di Dinas Kesehatan Provinsi ya. Dan ini juga dihadapi pada dua ada Satu Sehat lalu kemudian ada BPJS Kesehatan. Nah ini apa nih kiat-kiat atau harapannya ya kaitannya dengan mengintegrasikan yang teknologi digital yang ada di daerahnya. Mungkin 2 itu supaya nanti direspon oleh 2 pembicara yang lain. Silakan Dr. Ahmad dulu mungkin ya.
Ya baik, terima kasih Mas Gugu. Ya. Baik, terima kasih nih Prof. Ghufron tadi juga sudah mempresentasikan bagaimana BPJS Kesehatan yang luar biasa sudah melakukan transformasi digital di internal, namun memang perlu lebih banyak diketahui ini, Prof. Ghufron, dari sisi eksternal gitu, tentang apa yang sudah dilakukan oleh BPJS Kesehatan. Jadi memang menurut kami seorang konsultan perlu ya memahami kedua sisi, baik BPJS Kesehatan maupun apa yang dilakukan di Satu Sehat. Namun saya ingin meletakkan dalam kerangka ekosistem kesehatan, ya. Jadi memang harus dilihat secara menyeluruh begitu, tidak hanya sepotong-sepotong Satu Sehat saja atau BPJS Kesehatan saja, tapi harus dilihat sebagai satu ekosistem kesehatan. Dan ini perlu diletakkan dalam konteks stakeholder kesehatan secara luas, begitu. Kalau tadi Prof. Ghufron menyinggung tentang belum banyaknya penggunaan telemedicine yang sudah disediakan oleh BPJS Kesehatan. Nah, ini perlu didorong juga terkait dengan bagaimana fasilitas pelayanan kesehatan melakukan transformasi digital di tingkat fasilitas pelayanan kesehatan itu sendiri. Nah, ini yang kita perlu lihat secara keseluruhan dan bagaimana konsultan manajemen kesehatan bisa membantu fasilitas pelayanan kesehatan untuk bertransformasi digital dari level mereka. Nah, dengan memanfaatkan potensi-potensi yang sudah ada dari BPJS Kesehatan yang tadi sudah disampaikan, bagaimana dari sistem pembayaran, kemudian bagi anggota ya, kemudian telemedicine, adanya mobile JKN, ada iCare dan sebagainya, ini harus diletakkan dari bagaimana ekosistem kesehatan yang sudah ada dapat mendorong perkembangan transformasi digital di fasilitas pelayanan kesehatan. Mungkin demikian, Mas Gugu, terima kasih.
Baik, terima kasih Dr. Ahmad. Berarti harus belajar dan belajar terus karena hari ini mungkin 206
Pasti, ya.
juta, mungkin besok sudah 267 juta ini anggotanya. Setiap detik ada perubahan. Baik, terima kasih Dr. Ferry, mungkin ada komentar?
Baik, terima kasih Pak Gugu. Secara prinsip dari kami di Dinas Kesehatan dan fasilitas kesehatan kami, alhamdulillah kami sudah memiliki hubungan yang baik. Kami sudah memiliki hubungan yang baik dan harmonis dengan mitra kami di BPJS gitu. Jadi terkait dengan integrasi sistem dan lain sebagainya, sementara ini semua berjalan baik, termasuk ketika kami harus untuk comply dengan BPJS maupun comply dengan Satu Sehat. Karena integrasi sistem kami dengan BPJS memang sudah start dari awal ya gitu, ketika fasilitas kesehatan bekerja sama dengan BPJS. Lalu dengan datangnya Satu Sehat, tentunya kita juga tetap harus comply dengan regulasi yang ada. Kita pun mengupayakan agar semua fasilitas kesehatan kami bisa comply tentunya dan terintegrasi dengan Satu Sehat. Mungkin ke depannya harapan kami agar, karena tadi saya lihat tadi dari paparan Prof, ada beberapa modul-modul tadi ada terkait dengan TBC, ANC, dan lain sebagainya. Nah, mungkin ke depannya kami berharap ada koordinasi dan komunikasi yang lebih erat gitu ya antara BPJS dengan Kemenkes, agar modul-modul yang dihasilkan nanti seragam, terstandar, supaya kami di fasilitas kesehatan juga bisa nanti dengan mudah mengintegrasikan sistem yang ada. Mungkin itu aja Pak Gugu, terima kasih. Selama ini sudah dibantu juga difasilitasi oleh kawan-kawan BPJS maupun kawan-kawan Kemenkes. Terima kasih Pak
Baik,
Gugu.
terima kasih Dr. Ferry. Artinya upaya itu dilakukan dua-duanya ya, dan alhamdulillah DKI Jakarta bisa merespon ya kebutuhan keduanya. Baik, ini Pak Ghufron akan menjawab dengan lagu. Mana ininya lagunya? Mari kita dengarkan. Silakan. Ya.
Jadi ini bisa dilihat di YouTube ya, mengenai intinya bagaimana BPJS yang terakhir ini. Jadi mengenai transformasi mutunya, bagaimana bisa online dari rumah, antri segala macam lah. Jadi udah kita jelaskan gitu. Baik, saya kira ya, cuman sayangnya kita bicara tentang digital digitalnya bermasalah. Nah ini saya nggak tahu yang salah di siapa.
Iya.
Oke,
Seperti
ya.
yang kata. Baik, terima kasih. Mas Dimas, apakah kita masih ada waktu?
Dari rundown sebenarnya sudah habis, Pak
Sudah
Guru.
habis. Waduh, sayang sekali
sekali.
ya. Waktunya kita sudah habis. Mohon maaf Bapak Ibu sekalian, tidak semua bisa kita cover. Ada satu apa namanya tambahan dari Prof. Ghufron. Beliau akan bertanya dan siapa yang bisa menjawab akan dikasih buku. Benar ya Prof. Ghufron ya? Ya. Baik, silakan yang online boleh nggak Prof?
Boleh,
Oh,
boleh.
yang online boleh. Nanti ngirimnya gimana, Bro?
Oh, tinggal alamatnya mana saya kirim.
Wah, ya
Ya.
baik.
Kasih ke panitia.
Ya, baik,
Ya,
siap.
ke Pak Gugum nanti.
Ya, JJ, nanti kita bisa bantu juga, Bro.
Ya.
Baik, silakan Prof. Ghufron.
Siap. Enggak, jadi saya sebelum mengasih pertanyaan, komentar yang Pak Ahmad Hidayat dan juga dari teman kita Dr. Ferry, Dr. Ahmad, saya kira bagus sekali dan memang betul. Jadi harus dilihat secara lebih luas bagaimana visinya dan sekarang ini hubungan BPJS Kesehatan dan Kementerian Kesehatan itu seperti tadi saran Mas Ferry untuk diketahui kita hubungannya BPJS dengan Kesehatan itu terbaik sepanjang sejarah. Ya, untuk diketahui, saya barusan sama Pak M.Kes ya dan seluruh eselon 1 termasuk Prof Laksa yang dari sini
Ya.
rapat di Labuan Bajo 3 hari yang lalu.
Ya.
4 hari dengan
Saya lihat
M.Kes
tadi.
ya. Untuk diketahui Mas Ferry ya, jadi kita bicara tentang interoperabilitas, tentang lain sebagainya. Nah, jadi Pak Ahmad yang menyampaikan bahwa kita harus melihat lebih luas dengan sistem itu betul sekali. Dan sekarang ya, kita tentu tidak cukup apalagi sebagai konsultan hanya menguasai satu sisi.
Ya.
Jadi harus terus ya belajar. Kalau Pak Lutfan dulu ya kita dengar tuh orang belajar itu dari ayunan sampai masuk liang lahat katanya gitu. Ya, ini pertanyaan saya. Jadi apa sebetulnya perbedaan tanggung jawab ya, BPJS Kesehatan dan Kementerian Kesehatan? Apa bedanya? Waduh,
saya nggak boleh.
Yang lain dulu nanti Pak Gogo bisa.
Ya, peserta yang di Zoom juga sudah diperlukan untuk unmute.
Ya, saya mau kasih buku aja yang
Oke.
bisa
Ya.
jawab.
Ada yang jawab? Saya nggak bisa mengamati ini yang di Zoom ini.
Yap, di chat periksa juga barangkali ada yang raise hand Bapak Ibu. Oke, silakan Bapak Ibu yang di Zoom.
Makanya saya itu kadang memalu kalau masyarakat awam, masyarakat yang kesehatan itu sering nggak tahu apa bedanya nih tanggung jawab BPJS Kesehatan. Semua jadi satu, Pak.
Iya.
Kalau manajemen yang bagus, if you don't know who does what, that is not good management. Good management meaning that you know how to plan, how to execute, how to monitor, how to evaluate, and know who does what. That is the problem. But in Indonesia sometimes when we are talking about what is the responsibility of Ministry of Health, what is responsibility of the BPJS, they don't know. Because they don't know, then I ask, and who can answer, I will give book.
Ya, kalau gitu saya tunjuk, Prof.
Iya.
Ya, saya tunjuk. Nah, saya
Oh.
tunjuk dulu.
Kalau di UK, because it is tax-based system, uangnya, the money, the funding is from the government, so the NHS is under Ministry of Health, but it is different with Indonesia. Because the Indonesia is contributory system, so we have to collect the money. So therefore, BPJS is not under Minister of Health, directly under President. Yeah. So we are responsible to the President.
Okay. Selamat siang, Prof. Kebetulan saya dari mahasiswa S2 M.Kes. Saya kebetulan juga bekerja di Dinas Kesehatan Kabupaten Bandung. Tadi terkait pertanyaan Prof terkait perbedaan tanggung jawab antara Kementerian Kesehatan dengan BPJS, kemungkinan kalau menurut saya kalau dari Kementerian Kesehatan itu adalah mencakup keseluruhan terkait sarana prasarana, SDM, terus semua kebutuhan yang dibutuhkan oleh masyarakat Indonesia dari Sabang sampai Merauke. Dan kalau untuk BPJS sendiri itu adalah kalau menurut saya sih terkait nanti pembiayaan yang mengcover pembiayaan masyarakat yang ada di seluruh Indonesia mungkin, baik yang mandiri maupun yang biaya dari ya.
Prinsipnya, kalau ilmu ekonomi tadi saya jelaskan ya.
Yeah.
Ya, bedanya kan satunya supply side, satu demand side.
Yeah.
Jadi apa bedanya?
Kalau
ini ngurusi pembiayaan, M.Kes ngurusi pembiayaan juga. Gimana vaksinasi biayanya itu bukan kurang pas ya. Karena sama-sama ngurusi pembiayaan. Tapi bedanya yang membedakan.
Yang membedakan.
Kalau tadi ini ngurusi kesehatan seluruh Indonesia, kalau BPJS juga ngurusi kesehatan seluruh Indonesia juga, Papua, mana semua. Kalau itu jawabannya.
Iya.
Jadi sudah benar tapi kurang pas.
Kurang bumbu ya dok.
Ya, apa beda? Tadi saya jelasin juga.
Kalau dari BPJS sendiri mungkin dari sisi bertanggung jawab terhadap pembiayaan kesehatan.
Jadi nggak bertanggung jawab terhadap pembiayaan.
Bertanggung jawab, namun kalau dari BPJS sendiri itu terkait masyarakat yang baik promotif maupun preventif juga sudah dikelola juga oleh BPJS ya.
Iya.
Jadi tidak hanya yang sakit.
Kalau samanya nggak usah diceritain, yang bedanya aja. Diceritain samanya.
Ya kalau setahu saya sih bedanya itu tadi Prof.
Loh, makanya kalau bedanya itu pembiayaan, M.Kes nggak ngurusi pembiayaan.
Ya sama, mengurusi pembiayaan juga.
Terus apa bedanya?
Saya tambahkan petunjuk, tadi ada keywordnya personal. Prof.
Ya, kalau dari BPJS.
Kalau mau dapat buku boleh jawab loh. Boleh angkat tangan.
Saya dan Pak Gugu itu termasuk exclude.
Silakan, kalau mau silakan.
Nanti bukunya dibagi 3.
Enggak, bukunya ada 3.
Berdasarkan penjelasan Prof. Ghufron tadi, salah satu perbedaan yang mendasar adalah kalau BPJS itu sifatnya adalah bertanggung jawab untuk demand untuk individual healthcare, Prof. Berbeda dengan M.Kes yang itu base.
Ya. Bukan public health, betul sekali. Itu buku.
Terima kasih.
Kita itu istilahnya di dalam ilmu kesehatan itu UKP, Bu. Jadi kalau upaya kesehatan perorangan, nah itu tanggung jawabnya BPJS. Tidak hanya pembiayaannya, Bu, mengenai akses, tapi umumnya demand. Jadi ini supply side sama demand side. Supply side itu apa? Infrastruktur, dokter, alat. Nah ini M.Kes semua. Ya, kalau BPJS itu demand side, tapi cuma separuh. Demand side itu ada 2, public health atau disebut dengan UKM, upaya kesehatan masyarakat. Bukan BPJS. Jadi kalau ada TBC, surveillance, bukan BPJS, Pak. Ya. Jadi gitu. Nah kalau mengenai demand untuk KP, bagaimana orang bisa akses tanpa kesulitan keuangan untuk DM, cancer atau seluruh penyakit tapi tidak menular ya. Kalau menular, sistem surveillance-nya, deteksinya, apanya bukan urusan BPJS ya. Termasuk supply side tadi gitu. Bedanya ya. Namanya sih banyak tapi ini bedanya aja.
Baik. Tapi dikasih buku nggak, Prof? Sudah gemeteran sama keringetan tadi, Prof.
Belum benar tuh gimana? Samanya sudah banyak. Nanti aja nih. Sekarang berapa sebetulnya jumlah yang sudah di cover?
Wah, oke.
Ayo.
3 digit angka, Bapak Ibu. Ya. So only 3 digits
numbers. Tadi udah dijelasin. Ya.
Oke.
M itu million.
Saya Ika dari asisten HPM yang sudah tercover sebanyak 266 miliar.
Betul.
Juta.
Kok miliar? Salah.
Juta.
Oh,
Million
bener.
juta.
M itu million maksudnya. M itu bukan miliar, million. Oke, satu lagi ya. Loh tapi nanti nggak jadi dapat, nggak ada satu lagi. Tadi udah Jawa berusaha, Pak. Nggak ada satu lagi. Loh ini karena sana ada satu lagi. Bingung saya mau kasih apa pertanyaan ini.
Satu lagi, Prof?
Satu lagi ya.
Ya.
Baik, dalam sistem informasi ini, gitu, BPJS itu memiliki dashboard atau ya dashboard mungkin agak sulit itu kalau dashboard apa yang ini. Ini satu aja, termasuk kesehatan loh ya. Dan kita kasih dashboard apa yang diperlukan. Di wilayah itu berapa orang, berapa 10 penyakit terbanyak ya, dan segala macam. Nah, kita ini aja yang gampang aja. Di Indonesia sebetulnya belum banyak ya di negara yang bisa rekam medis itu dalam genggaman. Ya. Bisa dibawa mana? Indonesia sudah ada dan sudah jalan ya, bukan enggak jalan, bukan rencana, tapi sudah jalan. Apa namanya itu? Ya. Wah, langsung.
Langsung. Izin Prof.
Ya.
Dengan Andri dari KMK Prof.
Oh,
wah, ini Mas.
I Care JKN Prof.
Waduh, udah bener ya. Ya. Tapi sebentar, sudah pernah lihat belum?
Sudah Prof.
Oh, udah ya. Ya, oke. Gimana lihatnya? Di mana lihatnya?
Mobile JKN Prof.
Oh ya, oke. Tadi Anda sudah riwayat Anda tahu di situ ya.
Iya, Prof.
Rekam medisnya. Iya. Baik, terima kasih.
Baik, terima kasih Bapak Ibu sekalian. Kita aplaus dulu untuk semua baik narasumber kita yang sudah hadir di sini. Saya kembalikan ke MC. Mohon maaf jika ada salah kata dan silakan Mas Dimas.
Thank you, Dr. Guardian, for the inspiring session with Professor Ghufron, Mr. Ipung, Mr. Purwadi, and also the other panelists from the second plenary session. And we have reached our end of the session of today's workshop. We really appreciate your attendance in today's workshop, and we wish you a very nice day today. And at the end of the session, we would like to invite all of the participants to take a group picture facing to the rear of the area. So we kindly invite Dr. Tuan Lee and also Dr. Souvik Barat to join the photo session with our distinguished guest also. Oke, silakan Bapak Ibu peserta di sini, Prof, menghadap ke sana. Yeah. Oh, mohon maaf. Oke, terbalik, menghadap ke panggung. Oke. Oke, silakan Bapak Ibu untuk merapat ke sisi tengah. So please get closer to the middle of the auditorium. Yes, tamu pertama silahkan duduk. Tamu kedua, sisi tengah sih kosong, warna kursi abu-abu, Bapak Ibu. Oke, kursi abu-abu sebelah kiri masih. Okay, everyone. Okay. The first mobile phone. 1, 2, 3, smile. Say cheese, everyone. Cheese. Okay, another group photos. Sudah? Okay, one more request from our guest. Okay. Semuanya bilang cheese, say cheese, 1, 2, 3, cheese. Okay, that's all. Thank you very much. And friendly reminder for all of our participants, so please take your belongings and also your remaining snacks for today's session or today's workshop. And finally, this is all the end of the session, and Assalamualaikum warahmatullahi wabarakatuh. Thank you very much.
Mari-mari jangan lupa rame-rame daftar BPJS. Janganlah terlena, cek keaktifannya. Jaminan pelayanannya sudah banyak inovasi, mudah cepat setara, non diskriminasi. bisa antri dari rumah, periksa dengan KTP muda tanpa dibatasi 3 hari. BPJS semua serba mudah, iurannya sangat murah, gotong royong penuh berkah, tersedia promosi dan adanya prevensi, lakukan screening dan konsultasi. Jika ada masalah, janganlah Anda susah, hubungi BPJS 1 siap membantu. BPJS sistemnya dunia. Marilah dijaga kerjasama dengan semua.
Oke, gitu ya. Makasih ya. Makasih. Mari ketemu di apa?